frustrated about healthcare on free cancer screening take resident of the event. It will keep right now in Houston State leaders.
The new report shows there may be a reason behind why minority.
Checklist for the microphone. This will be about how loud they talk right there. 3, 4. Are you seeing it, Cole? 4, 5, 6. All right. So I'll get on conference. Two, two. Hear the fallback right there? Cool. I'll make sure it's on this one. 2, 2, 2. I won't. Yep, I won't turn this off. 2. Just a microphone check for a video record. Video record microphone check. This is be volume kind of right there. Video record microphone check. He's seeing something, I think. 3, 4, 5, 6, 7, 8. Let's talk softly. Like I said, we still have about 20 dB of headroom if we need it over here. Plus, he's got headroom over there. 3, 4, 5, 6, 7, 8. Yep. All right. Thank you. 4, 4. 4, 4, 4, 4. Take a picture of him? Yeah. Smart. I'm gonna turn all these on so you can see him.
I'm turning on these. Just
Let me rescan those right here. Hopefully, which is.
I can look at what these are on here, can I?
Yeah.
This is 534.050.
I'll keep all those at 400 then.
This other one, I don't even know what this one is because it's this the group and the channel number. But I'll take these off.
Thank you. little bit of interference today. I had some in the morning too yesterday. I got one more left again. I've got it all.
Okay.
Damn, that one keeps popping up too. Now, he's checking. He's got the frequencies here for his rooms.
Okay.
So
All right.
let's see. So that is 5 and 6, 7. Go ahead and enjoy your breakfast, man. It's no big deal. This is accent, man.
All right.
You know.
Yeah, I had a little bit of interference yesterday, just a little bit.
Hey, thanks for caring.
Had to do a switcheroo.
Right? We had 2 that we had to change during the show. That was it. Once we set.
Okay.
So maybe construction around here or something like that.
Yeah. Oh yeah. RF interference is big in the city.
This is Atlanta,
It's
man.
like your whole show.
Yeah, Atlanta's just like, especially with glass like that.
Yeah.
Everybody, come on in.
Yep.
I want everybody to have fun. Like a graduation outdoors with police scanners. Oh my gosh.
Yep.
So excited.
News van outside.
Yeah. 10 news vans.
Yeah.
No, we've never done this before. Come on, pick up, baby. Seek success. All right, we're all clear. We're totally rock solid again.
All right.
I can enjoy my sandwich too. Yeah, that sun coming in the morning is great on computers.
love doing this. I love that. I love that so much.
I would have said that too.
Good morning.
I noticed I changed lights a little bit. You'll be at the same place. How was your night last night?
I got to the hotel room. I laid down, and then it was 7 a.m. I was like, oh, it's time to go.
We're all kind of bouncing in first tubes. See what happens.
So what's crazy was I got up at 6 this morning because we had a beer at 7:30. Went out to the truck at like 6:30, 6:40. Pulled up my GPS because they get here at like 7:15.
Oh, yeah.
Okay, cool. And then we got on the road, and every like 2 minutes we drove, our ETA went up by 5.
Oh, it just kept going. Grinding backwards.
Yeah. We were losing time.
Time going backwards. I like that shower.
Yeah, that shower.
Oh, yeah.
Yeah, I stood in that shower for a full extra time this morning.
Is the shower included? The shower's included with the room?
All the time to get so hard.
Right.
You know what I'm saying?
Right. If we get shower included?
I have to shower every day, otherwise.
I didn't know that was included. Did it say
The day doesn't start. If I don't shower.
Shower's included? That's right. He never told us.
I think it was.
Told us what it up a charge in the shower.
I don't even drink tea. I get one of those with a couple like most of the I can't have the coffees. But you can get those Good morning.
Hey, Aaron. You only have a million things you have to do.
Right, so
But this is like one piece of the puzzle.
Yeah, like I call him, man, the first good-looking man in the world. Look at that. I mean, Jesus. I'm so jealous.
He's gonna hate me to say this, but this is my favorite. My baby. Sorry, yeah.
I'm glad you got some help.
Yeah.
I see you moving back here.
Family
It's so much. Everybody thinks this is your thing.
No, this is my
Everything.
thing.
This is one thing. Hey, you're welcome. You should be getting help out. We went to a whole day yesterday.
Wow.
Yes. Look at that. There's a pin right there, too.
Okay.
You're writing down numbers on them.
Okay, yeah.
If you remember, this board, auto mix is only 1 through 8.
Yep.
So when you have a cutover, it's going to go from, it's at 5 every person. It's basically 5
Okay.
people.
Yep.
Something like that.
Okay.
So when it goes over to like number 6, 7, and 8, those 3,
Yep.
try to spot quiet talkers.
Okay.
Put those on the auto mix.
Yep.
If you count, that's fine, but it definitely makes a difference. Otherwise, I'm auto mixing.
Yeah.
I'm the guy.
Yes, sir. Yes, sir.
So only 8 and 9 are the, and 10 are the non-auto mix.
Okay.
So if you see somebody that's got some bravado and they're talking to you, politicians usually good, but
Yeah.
I'm not picky, man.
Okay, gotcha.
Dr. Pickering, the head of the organization.
Yeah.
I'll show you who he is when he comes in.
Okay.
Anyone he's on, I always keep him on auto mix. Oh, is that
Okay.
him kicking off?
Yeah, yeah.
We might be on.
Well, this is today. Yeah. Yeah.
Ty can give you with that.
Yeah.
Tired?
All right. Wonderful, wonderful. So what are we, do we have any system? Are we just doing left or right? Are we matching the face to a number or?
Yeah, I mean, your system is your system.
Okay.
As long as you're writing down names and numbers.
All right.
So we chase them down. There's always one or two.
All right. Okay. Gotcha.
Speakers will come up, like we've instructed them to come up like 10 to 15 minutes before the session starts to get mic'd up. This guy will handle
Ty,
them.
right here. Yeah.
Ty. He's gonna handle them.
Nice to meet you, bro.
He's gonna help wrangle people.
Right, you don't really
Okay.
have to like do this part or anything, but if he's missing somebody, he's gonna let you know. And then you either find them if you know them or get Brandon, the client,
Here, put your headset
to
straight.
communicate with him and be like, I'm missing
Okay.
someone.
Okay. I never used these ones.
Take them. So they can come back here and get mic'd up.
Wow.
Definitely want them mic'd up
Okay.
for the session.
So the podium mic that goes on top of it, he knows what goes right in the middle.
Okay.
So, yeah, and then with this particular song, the number of the shit, like, little things you just gotta remember. This particular song has a different set for each stage in here, right? So this morning we have
Because you want the podium on there first, right?
so you gotta make sure 1, 2, 3, 4, 5. Yes, podium in the first.
They're moving it up there.
And this is why I work with them because they already know how I work, so I don't really have to like think about everything. So in the morning it's remarks. Just remarks are like cool, right? After that is just a session and it's just them discussing so what comes off the stage, right? But they already know this, so you don't necessarily have to remember that. It's just so you know what's going on. But the next session, if it's like 6 speakers, when the session is recorded, you may have to more than likely not, hey, we need a 6th chair on stage. It's usually over there, and they'll just pull it up. If it's 6 there on stage and the next session is 5, hey, I need 1 pulled off. Just make sure that the numbers match what's up there. Okay?
So the specific numbers.
Right here.
This would be 5 chairs.
Yep. So we already got 5 up there, right? But if you come in and it's like, oh, it's 6. Okay, so after the end of the session, you need to make sure that
So this one is 4 chairs.
right, remove
Okay.
it.
So after that,
Well, make sure it's the same room.
it's different.
This room, okay, because you know we work in 2 rooms. So.
Gotcha. So basically, once that one ends, go ahead and bring whatever and pull the trigger.
Sure. And then we have to also make sure that the hotel refreshes the tank with water bottles. So hotel is in water. So we ask for a box of water bottles ourselves to like refresh it and straighten up the stage. Just before the next set. So just make sure like any open water bottles, it may not even look open because sometimes people twist the cap back on, but if you see the levels drop, take it, replenish, make sure each one have 2 on it. What else? Make sure that you guys are on the same page when the session starts without any commercials. I normally
Check 1, 2.
without having those 3 sessions, so I'll remember, oh, Amazon's commercial played now, this place, now this one. Just make sure, even though they have it, it's your job to make sure that they have it. And don't leave make everything. Okay. What else? I mean, we don't have to like videos and slides for the most part. Hey, who's not over there?
Excuse me, guys.
Yeah, outside.
Okay. That's what
I just don't want cars coming in. Yeah, but that's just making sure that the products are not there to go. like it depends on the hotel or the space, but this one doesn't have like a backbone easily set. So we just sit over there. And then yeah.
Did you get a nibble?
Yes, indeed, I did. Much needed, much needed.
Yeah, it's all protein and love.
Oh man, I'm telling you.
So if they don't get over here fast, you're welcome to put your coat back here anything you want.
Okay.
And sometimes for flipping, so he takes a break, the video takes a break, I'll jump over there and you'll come over there. Let me show you the board itself. All this is the logo.
Mike.
Okay.
He has my check. And he has everything on my so in case
Your podium mics there,
yeah.
Zooms, not even video player. There's a few reasons. This one's always on. I never reinstated it right now.
Okay.
The podium's actually down here, but you don't need it. Then a box is running. It's 416 when we play.
Gotcha.
They're all for the videos. Lady, and I think I told you, it's pretty loud.
Ah, okay.
But the top end, I didn't even swipe it here to take the tie lines off. So it could break. We did that when I was supposed to swim. So it's bouncing.
Okay, I got you.
So what you go out there and get a carpet and center for it and stuff.
Yeah.
And online is it is what it is. So don't let it beat you up.
Yeah, no. Of course not.
Oh, let me get your number too.
Okay, yep. Yes, sir.
Type it in there?
Yep.
So how long y'all been working with Nina for?
Right? Anita and Lashane, they're working on it. 11 years. I knew you were looking for
Yeah.
Give you the frequencies for the other room just in case
Okay. Yes, indeed. Yes, indeed.
Right too.
It's
Refreshing.
It's beautiful, man. Running into a lot of bad texts.
I mean, you don't expect a lot.
Yeah.
And that's the only ones where 500. All of ours are trying to keep it the 400s.
Okay.
That's the only 500s we got.
All right.
But we're still out of his way.
Okay.
I mean, I just want you to be aware of it.
Yep. Absolutely.
He's all at 500 right now.
Okay.
We do take some hits.
Yeah. Sir.
Hey, Aaron, if you need a chair, go and grab one too. They're not taking long. Ty's gonna be sitting here to mic everybody up.
Oh.
And you'll be helping him wrangle stuff. So you two guys working together will be great. Nina's not in here all the time. You know?
Say again?
Nina's not in here all the time because she has so much to do.
Oh yeah.
So if you're gonna be in here, like her thing, we'll share everything we know, and it'll be a blessing for us. We don't know who these people are. You'll be working with Brandon. Have you met Brandon?
Yes, I've met Brandon.
Yeah, so you'll be working with him on everything too. He's great at helping. You'll meet Brandon.
Helping us put out face to
Fine, yeah, he's really yes. You know how to power. Yeah, power. I'm trying to knock down the 6 battery. These are all rebatteried up, but they have been dying fast. So I'd say after every other session, just change batteries. We got tons of them. 2 sessions. Yeah. On charge back. We got 2 batteries that were ID's bag. And we got I'll give you a handheld as a backup if somebody goes down on stage. Good to do that once. That you got a jacket on. Yeah, please power lock. I'll have it muted for you until you're sitting in your chair and the lights come up, and then we'll.
Thank you.
It's our pleasure.
I'm a hand person, so I like to have my hand.
Yeah. Well, no, I mean it's loud.
Yes, this is why I want to be here.
First handheld request.
Yeah, no, I was like, that's good. It gives you control. You can walk on the stage.
Yeah, exactly.
Yeah. So we'll probably run one.
So can I just?
First handheld, huh?
Yep.
I got a Sharpie here. There you go. It's all yours. Have a great presentation.
Thank you.
Good morning. Good morning. I'm pleased to say we are now on day 2. I was, crashing and burning last night and had a chance to look at the evening news before I went down, and was listening to the Canadian ambassador, and he was talking about how the relationship between the U.S. and Canada had changed.
They gave me a handheld.
Given the new sets of
I can't do a handheld.
relationships that
Okay,
this
I just need-
administration is contemplating. And I realized, and I think it was said many times yesterday, that we too need to think about
Okay.
our relationship.
It's fine. I just like handheld, so I asked for
and
one,
the
but
way
it's
in
okay.
which, when it comes to healthcare,
You sure?
we organize our community and
Yeah.
begin
Okay.
to
All right.
add some self-sufficiency into the
Are you sure? Okay.
formulation. And taking this particular moment to think
I wouldn't get in
about
trouble.
how we build down at the local level. One of the things I've really come to appreciate, certainly over the last year, that healthcare at the end of the day is about logistics. It's about logistics.
I haven't seen Heidi.
And what do I mean by that? What I mean is, when you think about healthcare,
She'll be here.
it's really a global process, from clinical trials to manufacturing. There are just systems globally that come together. So when you're in that doctor's office, you don't realize that there's a global economy that has brought you access to that life-saving care.
Alrighty, thank you.
Logistics. And part of the conversation is how that logistics gets organized and tariffs and all that, but it's still logistics. The problem in our community is that the logistics break
How's
down
it going?
at the point of care. Because there's a lot of policy and money and God knows what all that is not measured properly that impacts. Last night we were talking about disinformation, we talked about disinformation and vaccine. That's part of the logistical information system. So it's not just the products, it's also the information. The information for doctors, the information for patients, the information for community. All of that is part of how we get healthcare. And the point I'm making to you is, when you have disorder in the logistics, you're going to have disorder in the biology, right? They are, at the end of the day, linked. And the problem in our community, maternal mortality, diabetes, cardiovascular disease, kidney disease, is that the logistics are breaking down for us.
You know, I found out I was on the panel.
And those logistics
I
even
was
go
on the
to the
website
point of
looking
clinical
for
trials where we're not
speakers that Casey was going to be
participating
here.
in the data
And I'm like,
collection,
oh,
in the
I guess I'm not
information.
here. And then the next day, Gary calls me. I'm like,
So
hi, Gary. He's like, oh,
we
yeah.
have to repair, I don't even know if the word repair is appropriate.
I at least had
We
a
have to
week.
build the
So I at least had a
logistics
week.
Right.
if we want to
I
have
found
a
out
healthy
last
You had a
week.
week?
Yeah.
I had like a couple days.
And this goes back to what I was saying about 2050. That to build those logistic systems
Luckily,
is
it's
not going to
not
happen
too
overnight,
specific.
right? Those systems were put in place back in the 1940s. So you ain't changing all of that stuff tonight. So the conversation that we're trying to have with you and all of those centers and booths that we put out there are really a conversation about logistics. How do we incentivize the marketplace? Because I want to be real clear, I believe in shareholder value. I don't know anybody else, but I believe in shareholder value, period, right? I think that's the best sort of relationship, is a business relationship in which we're paying you to take care of us, no problem with me. So what I want you to think about as we go into this second day and how we leave here is the logistical systems that we want to put in place. Because NMQF is going to reach back out to you. Each of you do different things. We've got a different piece of the puzzle. And what we have to do is align all those pieces together. Even though you think you're not in healthcare, you are in healthcare. Because it's a communal act. And so the idea here is, how do we build those systems? And to our friends in industry, what I would say to you is, we are the emerging market. I'm just being frank and honest with you. I'm looking at the demographics. Demographics is destiny. You go to California, Texas, New Mexico, Georgia, Florida, Maryland, you know, right? And so there's a collaboration that we need to have so that the business that you're in supports our community, and our community is part of the business that you're in. So you can see when I was watching the Canadian ambassador, my mind was like, oh, okay. Message received. We got it. So I encourage you to listen today, think about the collaborations, and realizing that the system is imperfect right now, but how do we perfect it? How do we measure it? How do we make sure that value is being added into the system? And we're not just talking about the African American, we're talking about the American healthcare system for Americans. How do we do that? How do we stop denying people to the best possible care? And we organize that system. So anyway, I wanted to leave you with that thought, something to think about as you go back home, thinking about how these systems can come together. And as NMQF reaches out to you, it's a conversation. We're not telling you what to do. We don't know your community. You're in the community. You've got different challenges. But we need your collaboration, because I'm telling you where we're trying to get to. I'm telling you where we're trying to get to. which is to build those logistical systems, to harden them, so that we can provide high-quality, long lives to the communities that we've committed to. So anyway, I'm going to stop here and ask you to listen carefully during the course of the day. And it doesn't have to be a one-way conversation, meaning NMQF reaching out to you. You can also reach out to us. And then I also encourage you to go talk to some of our centers and see how we might collaborate. So have a great day. And I know lots of great panels are organized for you today. So thank you very much.
Right now, we're tackling some of the hardest challenges of our time and finding answers to the questions that impact every community. In the biopharmaceutical industry, developing life-saving treatments and cures, working to help those in underserved communities, and supporting patients in need are all just a part of our everyday life. And we need your help. We're working to provide better access to our industry and to make more opportunities available than ever before. We're offering scholarships to make education accessible. We're putting more resources into our communities and providing support and mentorship to those who need it. If you're looking for a career in medicine, business, or marketing, then you have an opportunity to create change and save lives. We're fighting to drive research and innovation forward while paving the way for progress. And we know this can only be achieved when we fully embrace diversity, when we make it part of our DNA.
Got it.
Got it.
All right, good morning, everybody. Welcome to day 2 of the summit. I hope you all had a wonderful day yesterday. We are very excited to be here today. We are going to be talking about advancing policy to improve access to affordability and to therapies and care. And I will say one of the biggest frustrations in my life has been not being able to access care. As an obesity patient, I was not able to get the treatment that I wanted for 11 years because, not policy, but I did not ever have employer-based health coverage that covered access to medicated weight loss. And now that I've had my treatment, I had it 2 years ago, I had weight loss surgery, and I think about what would my life look like had I been able to have surgery 13 years ago at this point when I first wanted it. I found out recently I already have arthritis setting in my knees at the age of 37. And it could have been so different probably had I had surgery a long time before I was actually able to get it. There's nothing more frustrating than knowing the care that you need, but you're not able to get to it. So we're gonna talk about today how we can advance policy and help people get the cares that they need so that they can have the life-changing treatments that they deserve, honestly. So I have an excellent panel here for you this morning, starting with Dr. Elena Rios. She is the president of the National Hispanic Health Foundation. We also have Ms. Courtney Christian, who is the Deputy Vice President of Policy and Research at PhRMA. We have Mayma Carmo, who is the CEO of Tiger Lily Foundation. And we have Ebony Morris, who is the Director of US Policy and Public Affairs at Pfizer. So I'm gonna start real general, ladies. If you could, please give us a little bit of what it means to advocate for policy to improve access and affordability for you. And I'll start with you, Dr. Rios.
Thank you. I think the importance of policy advocacy is in my blood. I've been here 30 years doing this. And like Gary and NMQF, I really strongly believe in the most vulnerable people in this country need a voice. And what better voices than our health professionals and community health workers and everybody that's inside the healthcare system. So through the years, I've developed organizational connections and networks with a lot of you here. And I think policy advocacy is important for everybody to get more involved with. And so the National Hispanic Health Foundation, I started working full-time a year ago. We have a new mission. Instead of looking into our memberships, organizations, and having conferences and chapters and developing the networking inside a membership association, we're taking all the membership associations of Hispanic health professionals and building an umbrella so that we can help them understand their role and responsibility to do more advocacy for all of our vulnerable people. The Hispanic doctors, the dentists, the nurses, the pharmacists, the PAs, even the dietitians and the mental health workers, the social workers, the community health workers. We've got national organizations that never talk to each other because they're so busy building their own associations. And I think that that's the beauty of our groups, of networking and policy advocacy for our most vulnerable. Access to care is a really big problem, and we are all involved in policies with all our partners to help increase affordability and access. And I think that's the biggest thing we can do. given what's happening, and we're going to talk more about what's happening and the changes that are happening. But let me just say that our mission is to transform the healthcare system with leadership, research, and education, and like I said, to advance the health of all our vulnerable communities, networking across organizations.
Thank you, Dr. Rios. And Courtney, what about you?
Sure, I think policy advocacy is especially important. I grew up in Florida, and my mom worked for the legislature. So I used to joke by kindergarten I understood all 3 branches of government and how they worked. But that also meant that I had a very upfront seat to seeing how policy was made, right? The sausage making that goes into policy, the advocacy that happens in the state capitol, in members' offices, and with staff. And so each of you in here today, I know you know that that's critically important for that to happen. I am at Pharma, which you all know is a trade association that represents most of the leading biopharmaceutical companies in the world, globally and domestically. And access and affordability is key to what we do, because if we are out here innovating all these wonderful medicines that take 12 years to get to market and cost billions of dollars, it's not any good if it doesn't get to the patient. And so we work hand in hand with Dr. Rios and with others in this audience to make sure that we are pushing for policies at the federal level and at the state level that make our medicines readily accessible for everyone. So that advocacy is very key for us to ensure that folks get access to the medicines that we are making.
Thank you.
So for me, praise be to God, I will be 20 years cancer-free next year. Thank you. And when I say that, it's almost shocking to me because I almost didn't get to be here. I found my tumor at 31 years old, and they told me that I couldn't have breast cancer, that I was too young. All the policies out there, NCCN policy, USPSTF policy, ACS policy, all said the screening guidelines were 50 years old. I was 31 years old. We know policy informs innovation and technology. So I pushed for mammography, but it came back clean. Because women who were using mammography, women who were older and white. And so my black, dense breast was missed during screening. I had to push for almost a year to get a biopsy. Within that year, my tumor doubled in size. I was having night sweats, I was exhausted, and I kept pushing. And 4 doctors dismissed me over a year. They said, "We don't understand, you're too young, you can't have breast cancer, what's your problem? Do you want to be sick?" I said, "No, but I don't feel well." And my body, I trust my instinct. And so a year of pushing against 4 doctors and against national policy that informs technology and, by the way, clinical trials. I finally got the biopsy against my doctor's wishes. And she called me the next day, February 28th at 4:44. I have a tattoo on my arm. And it says 4:44 to tell me I had breast cancer. It was triple negative breast cancer for which there was no treatment targeting TNBC, which wouldn't exist for the next, 13 years. So technically I should be dead today. It's because policy informs how pharma pushes for diverse clinical trials. So my story, for one, is why I'm called a unicorn, because I probably shouldn't get to be here, but I had all the barriers that I was facing, which were informed by policy. I had the screening guidelines that were too high, I had technology that were informed by the guidelines, and I had no clinical trial offered to me or a treatment available because of the policy. And so I thought, if I only have limited years to live, how can I use my voice to advocate for change? And I didn't know what to do. I was just a patient. These people had degrees, and they had these, big offices, and they had, what is the USPSTF? What is the NCCN? I'm just a patient. What can I do? And I met a woman named Debbie Wasserman Schultz, who was at the time 41 years old. I saw Debbie at an event, and she was speaking about being a mother and raising twins. And my husband left me after getting cancer. So I was single momming after having cancer. And I was feeling very torn about advocating, leaving my job, using my paid time off, driving to DC, wherever, my own money. And I had lost my house also because of my cancer treatment. I had to sell my house, use the money to live. And Debbie was talking about you know, being an advocate and being in policy. And I thought, I can't do policy. What is that? So I told her my story, and she says to me, she goes, you have a voice, and your voice matters. And we have to meet about this. And I went to her office, and in her office that day with Colby Dolan and Sarah Farhadian is where we began to write the Breast Cancer Early Act, which the CDC passed in 07, Courtney? And that has helped women across the country have better education on early detection and reach millions of women. And so I'll share my story in more detail later, but policy change is so important. And my goal is to empower women who look like me, who think that I'm just a patient, I don't have a voice, to be a badass, use their voice, and create epic, long-lasting, sustainable change that equates to life.
Yeah.
And Ebony?
That was great. So it's hard to follow behind that, but
I had no prep time, but just made it up.
But I think for us at Pfizer, it's a culmination of all of what you just heard. And so we tend to build our policy and advocacy agenda and our external engagement based on the principles of equitable access to care. So whether it's in the defensive, as was just discussed, as far as how do you break down barriers that patients are experiencing to get the treatments that they need, or are we looking at it from a proactive situation where we're thinking about in an optimal environment, what can we push for, and how do we elevate the voices of those that are affected, whether it's in an oncology situation, dermatology, and vaccines. How do we elevate all of the communities and voices to push for a full agenda? Our approach is typically collaborative, so we are not always out front, as Pfizer believes. We like to work in coalition and in concert with all of you in the room. I'm pretty sure most of your organizations have worked with Pfizer at some point on some policy issue, but it definitely, equitable access definitely drives all of our engagement on the state level and on the federal level as well. And you know, just for me, from a personal perspective, I never thought about getting into healthcare policy. It kind of happened. And then along the way, my sister developed severe lupus. And through that process and watching her with lupus and then other comorbidities with that, and seeing how a young Black woman like you described, where you're going through things and physicians are doubting your experience or saying that they've never seen anything like this before. And how could you have, you know, a rare liver disease, a clotting disorder? How do you have all of these things? And that diagnostic odyssey that we always talk about getting to a full, whole diagnosis and getting the care and treatment that you need. And so that guides me personally. And then what I enjoy working at Pfizer is that we really work in a collaborative experience and really try to highlight what does the patient actually need.
Great. Thank you all for setting the stage for this discussion. And so now I want to turn to what is the current environment looking like, right? We know policy is changing every day, and we are seeing a lot of things that maybe some of us aren't quite used to or not quite sure how it's going to affect patients in their everyday lives. So I'm going to start with you, Dr. Rios, and can you just tell us about some of the current concerns that we have for policy and the access challenges it's creating?
Yeah, I know there's a lot of issues to cover, and but I wanted to just focus on one thing at the beginning here, and that is the cutbacks to Medicaid. The cutbacks to Medicaid are going to be horrendous. 1 out of 5 Americans are on Medicaid. It's the largest insurance program right now in this country. And it is a federal program that actually has funding from states. So the states' budgets are going to be affected. The state budgets then are going to have less money for counties. So just to give you some numbers, because I was floored by this. First of all, 42% of all adults are on Medicaid right now in this country. Less than 10% of those are less than 10% of over 65. But it's mandatory. Medicaid in this country is mandatory for people that are at 133% above federal poverty level. Right now, federal poverty level is $15,000 a person. or a household, 15,000. So that's like less than minimum wage. But we have kids that are less than 18 on that, and that poverty level are mandatory to be covered by Medicaid, and pregnant women. Also adults, now even without children, and all adults that are part of SSI, or these are really poor people. And as you know, the Affordable Care Act increased the eligibility and increased the percentage of money that went from the federal government to the states that expanded Medicaid. So there's a lot more, that's why there's a lot more people on Medicaid now. But the Energy and Commerce Committee has been charged with cutting back $880 billion, and the majority of that is going to come from Medicaid cuts. The Republicans, and let me just say that there's a letter from 12 Republicans that have said, we don't want to cut the benefits, not benefits, we don't want to cut the harm to our people, but we're going to have to cut payments to the delivery systems, to providers. They're going to have to do deregulations, and they're going to have to cut down on administrative costs, which they're all calling fraud and abuse. That's how they're going to get through it. Now, the other thing is there's going to have to be new eligibility. And work requirements, for example, is one thing that's being talked about as an eligibility type of marker. The Urban Institute says if Congress shrinks the federal matching, which is another thing that will be on the table, 16 million people are going to lose coverage, and 11 million will become uninsured in every Medicaid expansion state. So we have a lot of people that are about to lose a lot of access and affordability to medications, to treatments. It's going to be a disaster. And not only that, but the benefits will decrease. States are looking at a per capita cap, and that's like a policy where the amount of money per person under Medicaid would be shrunk, which means states could have to pay another $2,000 extra for every person they want to cover. So not only is there reductions, but there's going to be even more reductions at the state level. The reduction of the ACA expansion match rate is another big policy being discussed, and reducing the federal matching below the 50% that already exists. So there's going to be taxes on providers that will be limited. Right now, I come from California. There are taxes on health insurance companies. There are taxes on providers. And other states have this way of finding more money for Medicaid, but they're going to limit. The idea of limiting the funding and limiting the spending is to limit all these kinds of innovative ideas to find money for the most vulnerable. And I'll just say that it's not only the payments to providers, but it's going to be the benefits, the extra benefits that states like to have, like our social determinants of health, the transportation, the meal plans, having ramps for disabled people, having air conditioning for people with asthma, all of the things that in public health we've looked at to be important for decreasing illness and diseases is going to be wiped out with the cutting of Medicaid. And so that to me is the most fundamental challenge of the changes that are about to get debated as early as next week.
Wow. And I think, Courtney, I would love for you to kind of continue on that thread of talking about what the barriers that we're seeing for prescription medication access, and when we're talking about those social determinants of health from the industry perspective.
Yeah, I think I saw on IG somewhere somebody said, I'm tired of living in unprecedented times. I want to live in precedented times. So I think there's a lot of, angst and uncertainty, certainly, that's going on. One thing that, pharma, we're really trying to do is just remain steady and true to what we do and what our values are. One of the ways that we think about, as Ebony talked about in terms of equitable access to medicine, is thinking of it through the lens of research and development, right? What informs that cycle? So you start at the very top with research and development. the medicine is made. Does the patient have receipt of the right prescription? Do they have the ability to fill that prescription? You know, are we getting information about the data once they take that medicine? You know, what any side effects are? How is it helpful? You know, what is the treatment plan? And then how are we using that data to inform the research and development cycle all over again so that every medicine that we make is better the next time that it's made? From our perspective, we have, you know, a few main policy priorities that we think are really central to medicine access and affordability, and they are the Inflation Reduction Act and accessibility through that. We're concerned about the pill penalty there in terms of access and what it may mean to the pipeline later on. We're concerned about the 340B program. I don't know if you saw just the other day, but Senator Cassidy released a report about fraud and abuse in 340B system and what are some policy changes that we need to make there in terms of making sure that there's transparency in the system. That 340B program was created to help medically underserved areas. And medically underserved areas, patients in those medically underserved areas be able to get medicine at a very deep discount, up to 60% that our manufacturers provide. But that has not been the case. It has been the case that hospital systems and others have retained those rebates, and patients have not been able to access affordable medicine. So that is a very keen policy issue that we're dealing with. We're also dealing with the issue of PBMs. Does anybody raise your hand if you know what a PBM is? Oh, great. Maybe you guys have been watching those middlemen commercials, but those, you know, we have these actors in the system that are doing the same things, right? They are retaining the rebates that our manufacturers provide for patients to have affordable medicine. And so we almost, at the end of last year's session, we almost had a deal for those rebates to be delinked from the system so that those rebates could get to patients. So there are like a number of affordability issues that we're thinking about. And all of these are policies that need to be reconfigured, right? They're misaligned incentives in the system that keep patients from getting access to a medicine when they need it, the right prescription at the right time for them. But it also drives affordability issues because, again, like I said, and like Ebony knows, you know, our companies are every day, you know, in labs trying to make the next breakthrough medicine for lymphoma and rare diseases and triple-negative breast cancer. And those advances don't mean anything if people can't access them. And so affordability and access are main pillars of our policy platform that we released back in February. So I encourage you all to take a look at pharma.org and read those in more detail.
Great. So thank you again for sharing some of the challenges and barriers that we see so that we have an idea of those. And so Mayma, I want to turn to you to talk about more about your story and the work that you do and how patients can advocate for these policy changes to help overcome these barriers.
Right. So I think policy can be weaponized or it can be a wand to help create healing and access for patients. In the past 15 years, we worked with Debbie Wasserman Schultz on the Early Act to get women aware of their breast cancer risk early and get more access to education. We've lowered the mammogram age to 40. That's 10 years below what it was when I got diagnosed and couldn't get mammograms. We pushed to get innovation to get a better screening for women who look like us, who have denser breasts and who are at risk for breast cancer. We've gotten barriers with clinical trials removed to get women more access to trials, to have them not get taxed as much and so forth. We work with Sheila Jackson Lee to get more TNBC, advanced research for women who look like me who have TNBC. And the 340B work is also been on our radar. To me, it's astounding and it's shocking and illegal that people are getting money to help patients who are at risk, and that money is being used for buildings and for salaries. We have women who, we just lost a patient. She had cancer, she lost her job, her husband left, and she was living from one drug to the next drug. So she's on a little pad right now. Here's a pad she's on, and the pad's in the middle of the water, and she could be drowning. And the next drug gets her, or access gets her better treatment. but she died because of these barriers that she was facing because of these misused policies. And so for me, policy isn't a thing that's nebulous. People don't understand what policy means, first of all. They think, well, I can't be a policymaker. What am I going to say? What am I going to do? But your stories do impact policy change. I was 31 years old when I got breast cancer. I work in government contracting. I had no idea how to begin a nonprofit, how to speak in public, how to do any of this thing. But I just asked God, how do I serve? So one of the things we do at Tiger Lily is we educate women to become what we call angel advocates. And the angel word stands for advocate now, to grow, be empowered, and lead. And women learn to use their privilege of breathing, that they're here for power to create change. They're trained on how to tell their stories, on how to write letters to members of Congress, how to testify in public, how to use their fear as a way to create faith for others to believe in policy, that it can work for you. Because policy has changed for the better in so many ways, right, over the past 15 years. We have 3 more TNBC treatments that are out there because of policy work. And I'm working on about 4 or 5 trials for TNBC because policy has pushed for innovative clinical trials. I do think that one of the things that has been challenging for me is that as a patient leader, we're in the gap. People don't trust in pharma. They don't trust in policy. And we're saying we have to build trust. We get it. They want to work with us. They want to work with us. Believe in them. Then we see what's happened over the past 6 months, where with one signature, it swept away words like DE&I, words like female and black and brown, and vulnerable and at risk. And so we really are seeing that patients have less protections than they had before, and that's why they have to be at the table when it comes to policy change. It's not optional. Because if you're silent, that silence could result in less access to treatment or even death by not having the right medication. So we trained about 800 women in 2023, black women, to become policy advocates, and they worked on over 30 different policies to help create change. And I think for me, the privilege of being alive is that you have to use your privilege for something better than yourself. And so we tell women who are patients that you have to use your voice. Whatever your story is, tell it over and over and over again. Before I pass on to Ebony, my daughter asked me when she was about 13, Mommy, you tell your story every day. Aren't you tired of telling your story? And I said, girl, yes, I am. But if one person hears my story and says, oh my God, I didn't know better and I can do better, and they live, guess what happens? She tells somebody else that story and they get to live. So the work we're doing here, that all of you are doing and that we're doing, is about the butterfly effect. It's about creating hope in a place where we feel hopeless right now. People are scared, they're angry, they don't know what to do. But, you know, whoever you voted for, the energy that Kamala brought in the room, that still exists. We still exist. And so my job is to empower people who are the most vulnerable, who aren't in these rooms, who aren't seen, to say that you have hope. There's a lady who's named Katherine Jackson, who just passed away a few weeks ago. But Katherine, in her last 3 years of life, became an angel advocate, and she loved policy work. She talked about the PDABs, Triple-Negative Breast Cancer Act. She's on the Hill. And the week she passed, she'd send me a message, and we FaceTime. She said, you all helped me find my voice. And my daughter will know when I die that I used my voice to create change so that she will have a better life, and my grandchildren have a better life. And policy can do that. And that's why I do what I do every day.
Thank you for sharing that. Excuse me, thank you. And so, Ebony, I'm proud to say that the center that I run here at NMQF, the Center for Sustainable Healthcare Quality and Equity, recently received a grant from Pfizer's Multicultural Health Equity Collective to do some education in communities about clinical trial diversity and the importance of it. Can you talk to us about how Pfizer, through the collective, partners with nonprofits to reach minoritized and underserved communities?
Sure. So first, I just wanted to piggyback on something that Dr. Rios mentioned, which was around just the full impact of Medicaid and things already being taken away. So that's somewhat actively happening. The administration has just alerted states that some of those extra funds that they received for some of those services already will not be renewed. So these are active things that have immediate impacts. And even for us at Pfizer, Medicaid, you know, even when I started at Pfizer over 6 years ago, you know, there was some, you know, from the business leaders like, yeah, Medicaid, but that's like separate. That was like a separate thing. And even within these last several years, just the growth just shows you the health status of folks in this country and the economic status of folks in this country. And it's a huge impact. And so even for us internally, in that recognition that Medicaid matters, and we also have to be heavily engaged in making sure that the program stays in existence and full and working with states. So that's a huge part of what we do. And part of that is through our multicultural collective. And so many of your organizations here in the audience may be a part of the collective. It's a group of internal staff and then around 40 external nonprofit organizations that we work with to help advise what we do. So even from internally, from our staff level engagement and how we develop our policy and advocacy agenda, we bring that to the collective to say, here's what we're thinking about. How should we go about this? Who are the voices that we should engage? We really take that seriously. It's a part of how we rank what we do internally, our working process. And we also utilize the collective and the voices to bring folks in front of decision makers. So when we engage different groups, we're not going as ourselves with Pfizer, we're saying, hey, hear from the folks on the ground, hear from the collective about what's happening. And then also, as Akia just mentioned, funding the organizations to kind of do the work, right? So it's not just us doing it. We have what we call the Communities Forward Grant Program. So this year, over $1 million to 7 national organizations from Council on Urban Indian Health, NMQF, National Urban League, to help push the work forward. So we really want to keep that engaged. And in this environment of, you know, denouncing DEI and so forth, I think Pfizer has, you know, committed and doubled down on the support of the underserved communities.
That's great. And thank you for that. And continuing to pull on this thread of these programs that are helping to advance these policies. Maima, you just shared that, you know, y'all help to train women on how to advocate for policy. Are there any other specific programs or things that you would like to share from Tiger Lily that y'all are doing?
Yes, I would. Okay, so I love this part. I love seeing a patient that comes to us and she needs help with breast cancer navigation, and we help her, and she's like, I'm only a patient, I can't do this, I can't do that. And we're like, but you're a baddie. What do you mean you can't do that? And so we train them on the Angel training. It has 15 modules, everything from, you know, knowing what Tiger Lily is, but more importantly, knowing your personal health history, knowing about screening, biomarker testing, clinical trials, policy, using social media for good, doing community engagement, being empowered to use your voice, knowing how to speak in public and all the things that they do. And we educate them on issues that they wouldn't understand, right? Because when I first got approached about the PDAP work, I thought, well, of course I want lower drug prices. When I had breast cancer, I had treatments that didn't work for me. Like I had one medication for nausea. I had rashes, I was itching, I was tired, all the things. And the medication I got was in my insurance plan, and I would itch and have wells from head to toe. The one that did work for me was not insured. So I had to figure out how to get that medication to be able to work. But people don't know that when you lower drug prices, it impacts innovation, it impacts people like us having better treatments. So we educate them on, here are the pros and cons of an issue so you know what to vote for. Here are the risks and rewards. But they are trained to write letters to Congress. They're trained to think about issues critically, not about what I want now, but what do I want that could be a future impact to my having a medication that could save my life. They do op-eds, contact members of Congress, share on social media, go to hearings. And we mobilize them to become an army that can speak up when an issue is not for a Black and brown community. The beautiful thing, people are always like nervous about speaking in public. They don't know what to do, but we really stress the importance of like, You know, no one's born an advocate, but you are born with a sole purpose to make a difference on this planet. Many of our patients, unfortunately, are women who are Black and brown and metastatic, or the treatments are not working for them. And so this policy work is almost a last chance to use their voices to create change, to help create the next clinical trial drug that can help be out there to get them that next lily pad or a treatment that can save someone else's life. And so once they're trained, we partner with groups like Pfizer, Merck, we partner with Courtney, we partner with many of you in the room, Pharma, Gilead, Amgen, so many others who support our work to be able to help us to be able to fund the work, to create state-by-state plans, to understand what are the challenges per state, and how do we advocate with angels on the state level and the federal level. And the beauty of all of that too is that these women who may not have had hope in the beginning are so filled with passion. I've never seen a patient more passionate than somebody who's living with cancer that knows that they can make a difference between now and when they leave this planet. And I wouldn't wish cancer on anyone, including myself, but the things that people have done during this time of like having disease and made a difference with policy has been incredible. Like I said, we've lowered the age for screening. We have dense breasts that have to be reported if you have dense breasts, so you get better training, better screening. We've helped to transform the PDAP work across different states. We worked on the Inflation Reduction Act, Triple Negative Breast Cancer Act, and over 30 different bills last year. And so the power of that is mobilizing a patient for medicine, for healthcare, but also telling people you have a purpose beyond your disease. You're not your disease. You are a person that has a difference to make in this world, and they're doing that. And our goal is to reach 1 million women this year around clinical trials and get them to be aware of trials and to be able to access them. And we think that making these commitments and having our sponsors here support our 1 in a Million campaign can help us get to that goal and reach women who are Black and brown to help them have better treatments to extend their lives.
Thank you. I love that purpose beyond the disease that you just said. I think that's probably going to stick with a lot of us in the room. That's a beautiful way to look at it. Thank you for sharing that. And so, Ebony, I want to turn it back to you for a moment, because you recently hosted a Health Equity and Action Summit, bringing together some leaders. And so I want to get some of those insights that y'all had from that summit about driving policy.
Yes, so the collective hosts a biannual Health Equity Summit in partnership with some other national groups. Morehouse School of Medicine is a partner this year. The National Association of County Health Officials was a partner. It was hosted in Oklahoma, so we also partner with the National Caucus of Native American State Legislators to host the meeting. And so the theme this year was obviously around elevating our Native community voices. But out of the summit, what was developed was an action guide to disrupt inequitable health outcomes. And so that kind of was the umbrella of the meeting. The first day was really about bringing young healthcare professionals together and those interested in healthcare research policy to link with those already existing experts in the field for mentorship and networking opportunities. So that was the first day. The second day was around just talking about the policy drivers that can shift our healthcare system to a more equitable space. And so some of the pillars the summit kind of looks at are around healthcare delivery systems and the actual development of physical, as we talked about, like equitable centers that people can go to for care, making sure that we know that there are definitely healthcare deserts in this country. So how do you grapple with that? We talked about like 340B and how that sometimes creates a disincentive to invest in areas that really need healthcare access, need the providers, need the actual centers. Diversity in data collection, clinical trials as well. Pfizer, through the Health Equity Collective, has a big initiative around promoting diversity in clinical trials, and that really drives what we do. We saw great success in working hand in hand with organizations, especially through the pandemic, and diversifying the COVID-19 clinical trial process. That was probably one of the most diverse and largest clinical trials on record for a vaccine. And so that's a big piece of it. Then how do you embed equitable policies into an advocacy agenda? And so for all of us in the room, in the profit space, in the pharma space, making sure that we are embedding that in everything that we do as well. And so that's kind of what the summit is about. Definitely look at NMQF's website around the collective and the summit. Feel free to reach out to me about that, but many of you are existing partners in that process, and the summit, really kind of is a culmination a lot of times of the work that the collective does.
Great. And Dr. Rios, can you share with us some programs or projects that y'all are working on to help advance policy?
Sure. I think many of the policies that have already been addressed, we are looking at too, and I'll just mention the 340B program. People don't realize that when it started in 1992, it was only for 3 hospitals, or 45 hospitals in the country, and HRSA was trying to find hospitals in underserved areas to give special programs for discounted medications to the poor people in their hospitals, just like our disproportionate share funding goes to poor hospitals for poor patients. But now there's 3,000 hospitals, and we have to start looking at how do you change policies to be more relevant to our communities. So at the National Hispanic Health Foundation and NHMA before that, we started a leadership fellowship program back in 1999 with $1 million from the HHS HRSA agency to start finding Latino doctors that were interested in their mid-careers who already had documented leadership training or leadership experience being on committees, for example, as minority admissions committees if they were in medical school faculty, or hospital committees if they were working in underserved hospitals, or even medical officers of clinics and public health departments. And we have found over a couple hundred doctors through the years and trained them in a leadership fellowship program. It's a 1-year program to expose them to the critical analysis of programs and policies at the federal level especially. And in the last 3 years, we started working in California to work with California's leadership. We've actually appointed doctors to advisory committees at HHS and advisory committees with the governor of California's appointments. We've also developed a lot of leadership potential that we wouldn't have had without having this type of a program. And just to mention the 340B and some of the ideas that have come out in our discussions of 340B is that there needs to be the location of the contracted pharmacies need to be in our underserved communities. You can't just have contracted pharmacies somewhere else in another state from a hospital. I mean, now there's mail order and all of that, but we really need more focus on our patients. The other thing is we need language services. There's so many Spanish speaking in this country that 340B should cover language services to help our Latino patients. And the best thing I think that's important is that clinics in this country had designations. They could only be built in underserved communities. And the hospitals that are getting all this funding for 340B aren't even in underserved areas. And we need to have eligibility requirements for the hospitals that get this funding so that they are taking care of poor people. And yeah, there's poor people everywhere, sure, but the community as a whole, when you look at a holistic approach to community policy analysis and planning, you can build more networks and get more people to understand that there are drug discount programs if you have an eligibility requirement for the hospitals that participate. And I think that going back to our leadership fellowship, what we're going to do next is increase media training of these doctors. I mean, one of our doctors is the Surgeon General of California. Another doctor became the New York City Health Commissioner. But we don't, our society sees Hispanics as, immigrants, gang members. I mean, we are in the health professional world, just like all of you, trying to make a better case for the programs that you all want. to help our communities. But I think the only way we're going to get more advocacy and visibility with our congressmen and our senators is if they know we exist in their communities and that we are part of the hospitals and clinics and medical systems in this country. We're part of the pharmaceutical industry. We're part of the insurance industry. But the Hispanic leadership has not been brought together. And that's what we need to do through our leadership programs, and especially the Leadership Fellowship for Doctors. But we'd like to be able to have leadership training for the other Hispanic health professionals too. And I just say we all need to collaborate on building our nonprofits, especially with what's happening with this administration. I just heard today about the steps toward martial law, and I don't know if anybody's afraid of this, but I heard it this morning. It was announced today, the newest executive order is gonna look at the determination of the military in this country to take over law officers, police. If the police aren't doing their job and getting enough people, finding enough criminals, the military is gonna be sent. And this is an executive order that's probably the worst. I mean, I can't even imagine what's going to happen in this country when people find out what this White House would like to be able to do. And so anyway, we need more leaders. We need more leaders to be visible from our own communities in our society to counteract what happens and for just putting forth the relevant policies like the 340B program, like the EPIC Act, like the clinical diversity, clinical trials, and how we need to have our communities involved in shaping those policies. It's really, really important that we get more involved.
Thank you, Dr. Rios, and that sounds like a great program. Courtney, I'm gonna come to you next, and before I do, if anybody has any questions, please go ahead and start to line up at the mics so that we can get to them as soon as we're done with this next question. But Courtney, from your perspective as a trade organization, would love to hear what work-specific programs you've seen that have helped to access care.
Before I get into that, I wanna jump into something that I hear all of you are saying, which is that policy starts with all of you. Yeah. As somebody who used to work on Capitol Hill, my first job was as a legislative correspondent. That is the person who answers your mail. Yeah. When you write your senator or your Congress member. And I can tell you, and I'm sure they're still doing it to this day, because I'm sure these processes don't change that much, is when they get letters from you, they get a letter on 340B, they get a letter on PBMs, they get a letter on breast cancer, the aggregate number of those letters, that gets tallied up into a report that member sees. So policy change, driving policy starts with you. It starts with using your voice. It starts with talking to your members of Congress at the federal level. Starts with talking to your members at the state level. So I just kept hearing that come up, and I'm thinking back to my LC days and thinking about the volume of letters that we got on any number of topics, but those things matter, those calls matter, those letters matter, sharing your thoughts and opinions matter as well. But from a pharma perspective, a few things that we've been working on is this issue of clinical trial diversity. We want to make sure that all of our medicines work the best that they're meant to work for any patient population, particularly for patient populations that are looking for a cure or treatment for a condition that's really prevalent to them. And so we established and funded through a grant the Clinical Trials Access Collaborative. I had to look at the name because it changed. But we partnered with the research minority centers, coordinating centers at HBCUs, Morehouse School of Medicine, Yale School of Medicine, to think about what would happen if we changed the paradigm of how clinical trials currently run, right? Where we usually kind of go set up in a community, run the trial and leave. What does it mean if we stay there and take root? If we understand who all the providers in the community are, if we make the trial accessible and put it in a place where people can get to so they don't have to worry about, oh, I have to take off of work and I gotta go all the way over town, or I gotta find childcare, who am I gonna get to keep my baby? How do we make it more accessible? And so we've set up trial sites in Atlanta, in Houston, in MUSC, in South Carolina, and it's a growing community, a network to try to figure out how do we reverse the numbers that we see in the FDA clinical trial snapshots. When we look at these snapshots and we see that all of us are very woefully underrepresented, how do we get those representation numbers up? Because I have a mentor, you all probably have heard of her, Dr. Frida Lewis Hall, and she always says we should be demanding a seat at the table, like Mama demanded that her doctor say, no, I'm not feeling well, let's look at this again. Another thing that we have been doing is our CARES program, and this is a program in which, a grant program in which we've given over $1 million in the last few years to think about what it means, what the nexus between social determinants of health and medicine access are, where are those pain points, where are the places where there are pharmacy deserts, and where do we need to fix. And so we've let out an RFP, there'll be another one coming in May, so keep your ears open. But like, we've been using that to drive policy solutions. What are the best scalable and replicable practices that people are finding around in their communities that we can fund to say, this is a thing that works, how do we scale it up? How can we make it replicable nationwide? We had a really great success story in Kansas. One of our grantees was looking at Braille accessibility on medicines. Wow. How do you get Braille on a bottle? And so they took that idea to a state legislator, and that state legislator said, you know what, I haven't thought about this. Let me introduce a bill. And so those have been great drivers, I think, of progress for us. And then we also have held a graduate summit. So really trying to do the same thing you're trying to do, Dr. Rios, is connect people from vulnerable, underserved communities to the industry. Who is our next CEO of Pfizer or some other company, or the trade association? Who are the next general counsels? Who are the next policy chiefs? Who are these people that we need to bring to the table? Because we need to have people that look like us at the table making decisions. And so those are the commitments that we have made as a trade association.
Right. Thank you. Are there any questions from the audience?
Don't be shy.
Don't be shy. Otherwise, I don't know if that means that it's too early, we haven't thought of questions yet, we've got to get the brains going. All right, I see one.
You haven't had your coffee yet?
Oh, no. Right.
It is early, but I think it's a quick question around the 340B piece. So I'm Yolanda Lawson, I'm the immediate past president of the National Medical Association. So I tell you that because I've heard a lot of 340B conversations. If most communities are like my community, hospitals are not one individual entity. They are systems, right? So they may be a system of hospitals and they may have clinics. Some of those may reside in underserved areas and some may not. And so when we talk about this conversation around 340B, I hear this conversation around the hospitals, they're using it for their more wealthier zip codes and patients, but how do they separate that? Can you just nuance that a little bit better to help understand the dilemma?
Yes. Well, actually, I just came back from Springfield, Illinois, talking about this issue with Black legislators there. And I think the issue with the 340B program is its growth, right? You heard Dr. Rios said it started out with 45 hospitals. It's actually almost up to 5,000 hospitals now. So between 92 and now, exponential growth. Our companies are giving about 60% in drug discounts to this program because we want to make sure that the program works, that it was the way it was intended to work in 1992, that these medicines get discounted to poor patients in medically underserved communities. But to your point about how the healthcare system is working, and I could get real wonky because I just had to write a paper about this. We've seen the financialization of healthcare, right? And all of these hospital systems are being bought up, these community hospitals in rural areas in particular, but in other areas as well, they're getting bought up by big conglomerates, bigger hospital systems. And what we see happening is that small hospital that was in a community is being used as the anchor hospital to draw down those 340B discounts. And then that hospital system is using that money that they're not passing on to the patient to build other facilities in richer zip codes. And so that's the rub that we're seeing there, right? They're supposed to be providing charity care, they're supposed to be providing discounts, the pharmacies are supposed to be providing discounts, but what's happening is that hospital in that community system is buying a drug at the discounted price and then marking it up as much as 150% to the patient. And so that's a misaligned incentive in the system, right? It's supposed to be going to the patient. And so that was one of the things that came out in Senator Cassidy's report last week to say, hey, we need to look at this. We see these in this big hospital system and Bon Secours. There was a big expose in New York Times a couple of years ago looking at the Bon Secours system where they looked at a hospital in Richmond, and I think the hospital was maybe the first Black hospital in Richmond, and it got bought up by the bigger hospital system. But what happened to the hospital in the community was that it got stripped. There was no more maternity ward, there was no more trauma care center, and people from that community had to get shipped out to another hospital away, some ways away. So what does that mean for health outcomes, right? That makes the health outcomes poorer when you can't access care right where you live. And so for us, for me, from an equitable access to medicine and healthcare perspective, that is a perversion in the system that needs to be fixed. So I hope that answers your question. Dr. Rios, you might have something else.
Well, I'll just say that's why I said we really need clearer designations of the hospitals. What is the measures that are going to be used, or the guidelines to be developed for hospitals? And then we have community health centers. We have a whole federal community health center system with designations, with boards that have to be 50% of the community. There's more regulations around community health centers than there are community hospitals. And there needs to be some connection so that we have a real safety net program, and that the 340B becomes a program of the safety net, not of the monster, consolidation of health systems. So I think that the buzzword is transparency.
I wanted to add something when you're done. So we're all sitting here, we're all healthcare quote unquote experts, and this is so complicated for all of us, right? I've been on countless panels around 340B, the PDABs, all the IRA stuff, and we're still trying to figure out what in the hell's happening. Imagine the average person on the ground who's working 9-to-5 job, has a couple of kids, or who's just busy, who doesn't understand, whose hospital closed down and had to go find someplace else, right? How do they understand these issues? It's just not easy. And so one of the things we're working on getting funding for, keyword, funding for, hello. We want to do a national survey to understand what people don't understand in rural communities, communities where they don't get asked certain questions. We have partnered with over 10,000 hospital locations, community oncology groups, over, I think, 5,000 advocacy groups across the cancer space. And we built that for a reason, for multiple reasons. But we want to do a survey and ask, what do they understand about these issues? Are they important to them? Will they invest time even in advocating for those issues if they have to think about their job and their kids being fed? And then based on what we gather, we want to do a survey that would cross cancer or women's health issues for the Black community. So imagine people that aren't at these tables, who can't be at the NMQF event or the Patients as Partners or all the health equity events. They don't have the time or bandwidth. We'll have insights into the policies. Then we would do recurring trainings throughout the year on different issues so they can understand what's going on. And Dr. Rees was saying that people aren't seeing us in their community on the ground. They don't see you. They don't know you. They don't trust you, right? So we're going to be doing the trainings virtually, but also on the ground, because people have to see you in the community. You have to have a relationship with them for them to even understand or believe that you care about them and be consistently on the ground with them. So I'm looking forward to getting this funded, getting it off the ground, because, I travel a lot for speaking events, and we have events on basketball courts, at rec centers, outside McDonald's. People are buying their food, and we're like, hey, want to have a conversation? But people learn different ways, so you have to go where they are to make sure they know you care about them, to be able to reach them on these issues as well.
Thank you. And we're almost at time here. I just want to see, Ebony, if you have any response to the question or any final thoughts.
Yeah, I did have, just to piggyback on what Dr. Rios said about community health centers and within 340B, and those original grantees. And so that's another part of where the rub is. So the program was set forth for a list of original grantee type entities. And they actually have a heavier reporting requirement and burden than these larger hospital systems. The hospital systems don't necessarily, through the expansion of the program, they don't have the same requirements as much as the grantees do. So that's another area. And I know for us as Pfizer, we see the grantees as a vital part of the 340B program and want to preserve that network. And the rub is, well, how do you get, like we just talked about, these hospital systems to really report out where they're spending their money? And then also there's a rub also with designating who is a 340B patient versus a Medicaid patient and so forth. But like what was just described, it's set up and made to be complex, right? So these are not easy issues to untangle. But I think with our collective voices and reaching out to any of us on the stage to kind of talk through what this means, the impacts, and what's behind the numbers is a way, I think, to really get at pushing forward equitable access.
Yeah, I think we have the opportunity to all work together, certainly across the stage and in the room. I believe I failed to introduce myself when I started the panel. So I'm Akia Blue. I'm the president for the Center for Sustainable Healthcare Quality and Equity here at the National Minority Quality Forum. It has been my absolute pleasure to talk with you ladies on the stage this morning, and thank you all to the audience for your attentiveness.
to discover what is not yet known. We pursue new ways to do science, new methods, tools, and platforms. We analyze the vastness of human and genetic data to gain new insights into disease and treatment. We look for ways to drug the undruggable, to tackle the most intractable diseases. We bring the best of biotechnology to enable new science by discovering and developing new ways to target disease. We use artificial intelligence and machine learning to engineer precision medicines and move science faster than ever before. We invite diversity to have the broadest perspective on the most urgent patient challenges. In our people, we find our greatest inspirations, our motivation, and our mission to serve patients. At Amgen, we discover what is not yet known to fight the world's toughest diseases. Amgen Research and Development. For every patient, a solution.
I do love a good pharma ad. I just am like, I'm a sucker for a good pharma ad.
Good morning. So hello everyone, and thank you for being here today. My name is Tammy Boyd, and I am the Senior Vice President for Government Affairs and Strategic Alliances at the Association of Black Cardiologists. Also, I would like to acknowledge our leadership who are here with us in the audience today, Dr. Anthony Fletcher, our President, Dr. Paul Underwood, our Board Chair, and also Cassandra McCullough, our CEO. So the title of this panel is Holistic Solutions to Improve Cardiovascular Care in Medically Underserved Communities. And then we also want to extend our sincere thanks to the National Minority Equality Forum for convening this timely and important discussion. I want to take a moment to introduce our distinguished panelists. Today's panel brings together perspectives across the healthcare landscape, from federal policy and government relations to industry innovation and patient inclusion and health equity-focused national advocacy. So first we have Janelle Gillings, the Director of Federal Policy and Government Relations at Merck, where she focuses on enhancing patient access to innovative medications. With a strong background in public health, Janelle leads and coordinates a range of federal public policy initiatives and advocacy efforts aligned with Merck's business priorities. Next, we have Dr. Pierre Theodore. He is the Executive Director of Patient Inclusion and Health Impact Inclusion and Belonging Office at Genentech. Dr. Theodore also serves on the adjunct faculty at Stanford University in the Department of Cardiac Surgery, where he remains in clinical practice. Next, we have Dr. Karen Macera-Cuevas. She is the Senior Director of Health Equity at the National Health Council. She works to help build health equity as a core competency through collaboration with other National Health Council departments. This includes developing programs, improving patient-centered outcomes, and working on current projects related to health equity. The majority of Dr. Macera-Cuevas' professional career involved health education, intersecting health policy, and clinical research. So before we dive into today's discussion, here are a few facts about the state of cardiovascular disease in America. Cardiovascular disease remains a leading cause of death in the United States, disproportionately affecting Black and African American populations. We're here today because of the burden of cardiovascular disease is not distributed equally. It weighs heaviest on communities that have long been excluded from equitable access to care. In rural areas, communities of color, especially Black and Latino populations, and region we now refer to as cardiology deserts, where access to cardiology specialists is scarce or non-existent. This is the area that ABC specifically is keenly focused on addressing. These are not just gaps in geography, they are gaps in access, opportunity, and life expectancy. For example, in cardiology deserts, the life expectancy differences can be almost 10 years compared to non-cardiology deserts. So I want to start first with Dr. Theodore. I'd like to start with you. Could you help us define what we mean by holistic cardiovascular care? What does a truly holistic approach encompass when we think about cardiovascular health?
Yeah, Tammy, thanks for that question, and I'm absolutely delighted to be here and join you today. And maybe I want to put a little bit of a finer point on something that Tammy just mentioned about the disparities in care. You'll hear a lot of facts that'll be shot at you from time to time about the differences in outcomes across populations. But a few years ago, a colleague of mine at Yale, his name is Harlan Krumholtz, did assessment of Black mortality in the United States over 20 years, roughly from 2000 to 2020. And what he noticed was 1.6 million additional deaths in the Black population versus the general population over the course of that 20 years. And that number, when I first read it in JAMA, just really hit me like a ton of bricks, just to realize the quantitative amount of loss that comes as a result of health disparities. And that's really one of the things I've committed my life to, starting initially just about 50 miles north of here, training in cardiac surgery at the Johns Hopkins Hospital. What we recognized, or what I recognized when I was training, was that I was always being taught that the disease existed inside of the patient. It was a patient's genetics, it was a patient's lipid profile, it's a patient's blood pressure, dietary problems, what have you. It's the patient's problem. And we really failed to recognize that it doesn't originate in the patient itself. It's this collective set of political and economic and social issues that really culminated in the disease that we saw in an individual patient. So in my mind, a holistic preventive care in cardiology boils down to that recognition that the drivers of cardiovascular disease do not originate in the patients themselves. And then asking ourselves at a fundamental level, what can we do to mitigate those risk factors that ultimately lead to disease? So that comes from an individual standpoint, an individual patient standpoint, by things like managing blood pressure, making sure that lipid proteins are evaluated, making sure that glucose has been evaluated in the patients, and diets are under control, and exercise. Those are the kind of standard solutions for an individual. Those are easy. A Google search will get you those answers. I think it's a more difficult and challenging questions. What are the policy, social, and structural issues that we need to address? And that's what I mean by holistic care, broadly speaking, Tim.
So thank you for that insightful perspective on what constitutes holistic cardiovascular care. So now I'd like to shift our focus to how we implement this approach within diverse communities, and so as we consider the importance of cultural competence. So Dr. Theodore, again, can you help us understand cultural competency and really how that may shape health outcomes?
Sure, it's back to me again. So yeah, I guess I kind of keep cultural competency because it's a complicated term. It's even a controversial term. What does it mean to be competent in somebody's culture? I think I kind of throw that term a little out. I just use the term understand and understood. Just as an anecdote, my son was asking me about did I have any tips for him on dating? And I said, this is a tough conversation for a son. I said, look, don't worry about being so interesting to everyone you meet. Just try to be kind of interested in that person, right? And in a way, cultural competency, whatever that's meant to mean, but sort of a cultural humility and a cultural understanding is about trying to understand first, right? Like if you start going in with the first idea of how do you modify someone's diet, for example, or how do you suggest that they take a particular medication, but you don't understand the context in which that patient is choosing, or that person is choosing diet or chooses a medication, that strategy is bound for failure. So I think of cultural competency, again, that's a term I'm not a big fan of, frankly, as really ultimately being understanding before you seek to be understood.
Thank you for that thoughtful perspective on cultural competency, its alternatives. And then your insights on understanding the patient's lived experiences really highlights why the terminology is important. So building on the notion of trusted messengers, Dr. Cuevas, I want to turn to you. Can you describe how the National Health Council has engaged national audiences on the topic of cardiovascular disease through trusted messengers?
So thank you very much for that question, Tammy. So just to give a preface about what the National Health Council is about, we have about 180 member organizations, NMQF, one of our member organizations, and we're the leading patient advocacy membership organization. So we have associations, we also have business and industry as part of our breadth and umbrella. And, we were approached to really design, really thinking about what we would look like and how we would craft the Trusted Messengers campaign. So within that, our research program and equity team came together and we're just really thoughtful. What does that include and what does that ingrain? And really for us, that meant having trusted messengers that were coming from many parts of the United States that worked in cardiovascular programs, not only grassroots, but were really individuals that maybe worked with local health departments. We already heard that in the prior discussion today. But also engaged with really being much more resonant and understanding as to how community speaks when it comes to cardiovascular risk in those respective areas. So the Trusted Messengers campaign then brought together 6 experts that then represented that. So for example, we have someone who is the co-leader of the Illinois Community Health Workers Association. This is someone who at the grassroots level throughout the state of Illinois is very much ingrained in terms of how do we do cardiovascular education, how do we do diabetes education, working with diabetes educators. And we also had another person, for example, that was one of the 6 trusted messengers that came from Arizona and worked with Native indigenous populations. And we wanted to have these 6 representative individuals to then convey a message of what that meant. And so part of that then was bringing together camera crew, having conversation with them, and then posing questions to them. Okay, what does that look like when you're actually boots on the ground, trying to get people engaged? We know that there's issues of trust throughout many communities, but let's say, for example, you are at high risk, you already have a hereditary family history. How then do we get individuals, communities, families, sometimes those at risk? Sometimes we were having conversations, right, of maybe having males in the family that didn't want to, were maybe having symptoms but didn't necessarily want to engage. How do we get them engaged into our campaign? So as a result of that, we did a campaign that went across the country on TV, on social media. We've had a reach of about 11 million so far and counting. Many of you probably have seen our senior VP, Omar Scantrias, on in between, ads, TLC, a lot of other ads on cable TV that really speak to these snippets and these shots as to targeting specific areas. And really our reach was looking at specific geographies, right? So really making sure we're in areas, for example, of the Deep South where there is increased risk, markers as well. In order also to do that, we had someone in our panel, Caleb Sned, who actually I engaged, and I'm going to really speak to, the intersectionality of not only working in your professional organization, but also professional organizations, who spoke to working with Black churches and, around the Atlanta area, and what did that mean? And what happens when you actually run out of funding too, which those of us who work community-based work know that this is not the first go around of being short on funds and having to do integral work. So really captured the names, the voices, and the different perspectives that we want to see when we have a national-based awareness and engagement.
Thank you. And so even as we talk about holistic approach, I know you have experience also in Illinois and then specifically working with the Latino communities. And so what has been your experience working with Latino communities in accessing medical and safety net services at the grassroots level?
So grassroots level work, as we know, has different parameters and different levels of engagement. There's a lot of conversation when we talked about Latino communities that we're not all a monolith. We understand that. I think that at the end of the day, what we're trying to do is curate, maybe necessarily not only by country of origin, right? There's a predominant Mexican American population in the state of Illinois, but also to what are health priorities, right? So like, for example, you're trying to look at indicators that may be putting individuals not only more at risk, but also, we haven't really talked in recent time, but also there's the notion and the understanding of the Hispanic paradox, right? What does that mean? When individuals migrate into the United States, yours truly included, right? So like when we talk immigrant journey that looks very, very resonant, particularly for those that are first generation, you have to change your lifestyle, you have to change your environment, you have to change how you eat. And that therefore creates acceleration of specific cardiovascular indicators, right? So like many of us that may not necessarily, may have genetic predisposition, Dr. Pierre will have much more expertise in that space than I do as a health educator. But then that then means that then we're having conversations with communities of like, what then do we have to do to think about alternatives to eating when eating and culture are really highly tied. And then besides just being in community FQHCs, community-based centers, and all of those great things, then when we complicate, then how then do we engage with medical systems? And for a lot of people, it's really hard to just visualize unless you do that grassroots level work of the navigation that involves, anywhere from transportation, physically getting them in, to translation, but also understanding of what are all these consent forms and what do they all mean? And I have a cardiovascular issue, but how then do I then address it, right? And go through the system, getting families engaged, having conversations of potential complications. In addition to that, I was also part of one of the most influential cardiovascular, studies, the study of Latinos, NHLBI funded, has gone on for many, many, many years. That also was a cardiovascular experience where we were engaging communities to really understand where are we in terms of landmarks and markers and understanding. Those are entire conversations where you can't necessarily see, well, I'm not at risk today, but that doesn't mean that I'm not going to be at risk tomorrow. And sometimes finding things under CT, MRI, a lot of advanced imaging that then starts to see the effect of potential cardiovascular disease with Latinos. So there's a lot of these types of experiences that, yes, we speak to intersectionality, but then how then does that look like in terms of the continuum of care? And then how does that look like also in terms of behavior change, right? So when we talk about cardiovascular disease in Latinos, we're not just talking just about prevention, but then if they then get to the point where they need bypass surgery or they need other advanced cardiovascular treatments, where do they then go from there? And then how then do they maintain it in a system that they're still trying to assimilate in a culture, right? So a lot going there to unpack, but a lot of value in terms of space as to where we're moving in terms of having more knowledge as how to best support communities.
Thank you, that's very insightful. And then just want to pivot back to Dr. Pierre, Dr. Theodore. Can you also speak to the effective community-based interventions?
Absolutely. I think, let me give this from the perspective from a pharmaceutical organization, which is, we have a sort of core mandate, which is to discover and develop drugs to introduce into medical system to help to change the trajectory of disease. That's kind of the core of what a pharmaceutical company does. But let's not mince words here. Just developing a drug alone is not sufficient to address the needs of patients. That's not what patients are asking for, is new and novel drugs. They're asking for a reduction in the risk of disease. They're asking for a reduction in suffering as a consequence of the disease. In order to get to those answers, to really get to those complicated problems or solutions to those complicated problems, it requires having a presence in the community. So I'll give a couple examples from Genentech's perspective. We put into place, I've got some colleagues here who have founded this program called the Health Equity Symposia, where we bring together community leaders. We make sure that there are patient advocates in the room, make sure there are policymakers, that there's providers, healthcare system directors. And we do that often in the community itself. And the reason is to sort of raise the voices of those that can inform others as to what are the policy perspectives that are needed, what are the clinical strategies that are needed to reach patients, what are the health literacy phrasing that's necessary to reach the patient. And so we've been able to reach around 25,000 people at this point through these health equity symposia alone. That's one example. Another is through a set of partnerships, and these are partnerships all the way from the federal level, working with the Congressional Black Caucus Foundation, for example, or NMQF is another perfectly good example, or the National Hispanic Health Foundation with Dr. Rios, who's just on the panel. Those are examples of partnerships we've engaged in. And it's because we have to reach into the community to actually have some impact. We try to measure our success really by how many people we're able to reach. It's not something that translates into a balance sheet per se. It's how do we actually raise the level of the conversation, engage in dialogue that we think is meaningful, and ultimately translates in our core mission, which is taking those drugs that we're developing in that research and development pipeline and actually reaching the patients where we can have the maximal impact.
Thank you. And so, Ms. Killings, when I come to you, talk about an area that I really like a lot, really want to get into the policy aspect. Can you talk about how can federal policies enhance access to preventive care and screenings for cardiovascular diseases in underserved communities?
Sure. Good morning, everyone. I'm Janelle Gillings. Happy to be here. In terms of enhancing access and affordability and screenings for cardiovascular patients, I think we've seen these advances in medical therapies that are treating cardiovascular diseases, but we still see a lot of disparities in access and also adherence in minority communities. And a lot of this is because of like the insurance practices that we're seeing in both Medicare, commercial, there's practices such as prior authorization, step therapy, and also like restrictive drug formularies that impact and create barriers for patients trying to access care and medicines. So in thinking about like what's happening right now with the federal policy landscape, we're seeing that there's deliberations around Medicaid cuts. And what this means is that I saw today that that the Republicans are looking at the match that the federal government provides to states for Medicaid expansion is around 90%, and the states will contribute 10%. Well, they're looking at pulling back that that amount to 50%. And so this means, you have more people losing access. States are having to think about raising taxes to make up for that shortfall. The other thing is that we see, even with Medicaid expansion, that the states that have expanded Medicaid, they have markedly less uninsured patients with cardiovascular disease and other risk factors. And they've also seen, greater reductions in racial disparities to access to care compared to states that did not expand Medicaid. The other thing about Medicaid that is why it's important for cardiovascular patients is for those who are dual eligibles, like my grandparents, for instance. Medicaid provides services, like they provide long-term care for patients who are, they have cardiovascular disease and they also need nursing care, other long-term care supports. So by cutting or making changes to Medicaid, that also impacts the direct care that a lot of these patients are going to have. I was hearing stories about people not necessarily understanding that Medicaid was the one that provided those kinds of services, and so there's a lot of concerns about, well, my grandmother is she's in a long-term care facility. She has cardiovascular disease and all these other factors, but you're saying that if they cut Medicaid, that she could potentially lose those services. So that's the reality that a lot of people are thinking about right now, and as to why continuing and strengthening Medicaid is important in enhancing access. The other component, to the systems around the Affordable Care Act. And I think we've kind of seen, like, I call it death by a million paper cuts, because over time, you've seen a lot of challenges to the Affordable Care Act in terms of, like, putting in more barriers for people to be able to afford their health insurance premiums. And so it's important for now that right now they're offering low subsidies for low-income individuals to get health insurance through the ACA marketplaces. And as part of the American Rescue Plan of 2020, Congress increased the ACA marketplace premium tax credits to ensure that Americans had access to affordable health care, especially through the pandemic. Um, in 2022, Congress extended those tax credits, but they're due to expire by the end of this year. And as to seeing like how the deliberations are happening on the Hill around Medicaid and around other health insurance or healthcare issues, that is a concern because by not extending these tax credits, again, you're going to see more people not being able to be able to um, buy insurance or stay on the plan that they had because they've lost coverage. So some other factors that I was, thinking about with definitely trying to enhance access is around supporting telemedicine initiatives. Um, I think telemedicine has been amazing, especially through the pandemic, with allowing more people, especially in rural areas and other areas where there's less healthcare facilities available, being able to access healthcare and making sure they're able to get preventive services, even if it's an initial screening on a call, then going into a facility. So by ensuring that telehealth services, for preventive screenings and ensuring that those are available, and also that they're reimbursed by Medicaid and Medicare, because again, that is usually an issue that comes up in terms of funding at the federal level. Um, Another area that we've been thinking about in terms of access is really around addressing the outcomes and quality of care with patients with cardiovascular disease. And so this entails trying to see if the Centers for Medicare and Medicaid (CMS) um, address. There's a currently in the space around high cholesterol. The current measure that they use in this particular space is based on if a person is, they get screened for high cholesterol and then they get on a statin. Um, this particular measure does not look at, the LDL levels that is needed to see if the person is improving in their care. And what we've also seen is that Black patients with, high cholesterol are less likely to be prescribed statins compared to white patients. And women are also less likely to have statin therapy prescribed or appropriately escalated when, compared to men. So we have been working with a number of organizations like the American College of Cardiology, American Heart Association, in looking at reinstating a routine LDL monitoring measure. And so this would be replacing the statin measure because we think that the lipid panels really should be reconsidered as the quality and performance measure of LDL control. And this would help to reduce cardiovascular morbidity and mortality and improve better health equity. So this is something, again, that I think is important in terms of addressing the need for better screenings and better access.
Thank you.
Can I-
That was very
Can I
insightful.
build on something
Yeah.
that Janelle said? Because I think you did a fantastic job of outlining some of the real challenges in healthcare systems that ultimately drive disparities. But to adding on top of what you just said, if you look at the perspective of the current federal government, which is really and essentially to gut science at a broad level, everything from NIH funding to the capacity and function of the FDA to higher education to K through 12 education is this sort of generalized attack on scientific advancement. And in lieu of that, there's this idea of, well, if you can repatriate manufacturing to the United States, that's somehow going to improve the business of healthcare. But the business of healthcare is the delivery of the care to patients in need. It is the clinical research. It is the maintenance of insurance strategies that allow patients to have access to care. So there's an interconnectedness. It's a web, which is what you're describing, a web of factors that leads to a successful healthcare system. And my concern is that the current federal policy is gutting elements of that. It's like a car where you're like, oh, I'll just throw that carburetor out and that left wing, the front wheel I don't need, I'll take that one out, I'll take the exhaust pipe out, and just sort of see how this car works. And that's a little bit of what we're facing in the current environment. So my concern is that the issues that you brought up, which are critically important, are all being undermined by federal policy that's going to cause the healthcare system to begin to sort of grind to the halt, to sort of push that metaphor in the extreme.
Absolutely.
And I definitely agree, Dr. Theodore. Dr. Ms. Gillings, can you also elaborate on, when we talk about the Make America Healthy Again platform, are there things that we need to consider in terms of addressing cardiovascular health in underserved communities and really building upon what Dr. Theodore said as well?
Yeah, I think when the Make America Healthy initiative or executive order was disseminated, it included, that there will be a focus on chronic diseases. They mentioned cardiovascular disease and, diabetes and other chronic diseases, and mentioned that, with they're going to be looking at the root causes of chronic diseases, but in the executive order and in a lot of the communications around MAHA, I call it, there really isn't anything around access, looking at health equity, of course, because, they're getting rid of DEI equity in a lot of the, materials that they have on the website and also through the research. There is also, I think, there's a tendency to also focus more on addressing or looking into like food dyes, vitamins and supplements versus like looking at actual innovative therapies that can address a lot of these chronic diseases. And to your point about what's happening right now with a lot of the cuts. So you're seeing that there are cuts happening. There was 10,000 positions that were targeted for RIFs in Health and Human Services. And you're seeing that they're moving a lot of these agencies around. Like HRSA got moved under this new, I guess, agency called Administration for Healthy America. And you also see that they're taking parts of like other, divisions and putting it under AHA, MAHA, AHA, they're saying like they're consolidating and trying to make things, more efficient and also like cut a lot of costs. But what's happening with that is like you're seeing a lot of upheaval. You're seeing a lot of a lot of the staff that have been in a lot of these positions in the government, especially around with CDC, with primary care, HIV/AIDS, like a lot of these issues that are very important. They are, we saw today that there was a news blurb about because there were cuts to the FDA, there's a company that has a rare disease product that basically they were supposed to be getting some kind of approval, and you're seeing now that because of the FDA cuts, it's delayed. So you're seeing, because of these shifting of, with with the different agencies and also with the staffing and just, having this, I guess, cynical view about healthcare around like, basically equity. We're already seeing the challenges. And I think, as much as, MAHA originally, when, you hear about like, oh yeah, we're improving, chronic diseases, it's really, it's a conundrum because you also have what's happening with Medicaid. You also have, what's happening with, just like with everything else with, pulling data off the websites. So people are not able to understand like, some of the surveillance data that's needed to understand like where the disparities are in a lot of communities. So I think for MAHA or, Make America Healthy Again, um, I just think, they mentioned the focus on chronic diseases, but they also have mentioned that they would rather take the funding away from infectious diseases and move it over to chronic diseases and not pay attention to the fact that you also have to think about that particular area of health because, a person can have an infectious disease and also have a chronic disease. So that is the reality that we're in right now with this initiative. And as much as we're saying like we are trying to monitor like what's happening in this space, there's still a lot that's unknown. just because like they're still, you know, moving things around, breaking things. I also support our HIV franchise, and I have been really like talking to a lot of stakeholders in the HIV space about like what these changes have meant for them, and also like, you know, for instance, they're trying to cut the CDC prevention funds for access to PrEP, or like, you know, other initiatives that would help access to, you know, various services for HIV. I mean, this is real life, you know, impact, because there are people who are, you know, they're, I guess, concerned about getting more opportunistic infections because of, you know, they might not be able to access their, and you know, their treatment because of the, you know, what's happening with like community health centers, some, you know, some of these other aid service organizations that provide services. So I think yes, you know, addressing chronic diseases is good. It's something we, you know, of course we should be doing, but not at the detriment of, you know, dismantling the entire public health infrastructure and being anti-science.
Thank you. And I want to ask a quick question to you, Dr. Sarah Cuevas. Just you're on the front lines in terms of the National Health Council, and as we talk about the climate that we are now in, and I also want to come back to Dr. Theodore and Ms. Killings to hear about what your companies are doing. But Dr. Cuevas, I want to start with you. You know, in terms of the current climate, how has that impacted the health equity programs of the National Health Council, member organizations, and how is the National Health Council responding?
So, so when I opened, I mentioned that we represent 180 organizations, and there's 180 responses. That's what that looks like. So that looks like anywhere from having organizations that have rebranded positions that were in health equity into strategic alliances or operations or something along that line, to boards of directors that are reconvening with CEOs and saying, is this our vision for health equity? To organizations that are essentially standing on business. They are saying, we're doing this no matter what. You know, and so I really think that in this environment, it has created a lot of that course direction and vision. Much of that is grounded in the leadership of our respective organizations. The National Health Council has one of its pillars. It is health equity. I am in an inaugural role, have been doing this for more than 2 years, have strong health equity experience. But the response to that, a lot of it is then oftentimes having a lot of connections and alignment with not only leaders, but with individuals that are representative of our member organizations that actually do the work. So individuals who have now had CDC funding cut. I just went to a meeting, for example, one of our member organizations, the Epilepsy Foundation. That was the last of their funds that we had at Harvard University, the last. And they got cut. We have some organizations that are looking at alternative fundraising strategies, right? A lot of, you know, entities are trying to say maybe like philanthropy might fund this, maybe industry might fund this. But these are multi-million-dollar contracts, right? I mean, the problem is that gap is so wide, you can't necessarily like, you know, just like cover it with your thumb when it's like a huge gaping hole. So what we're doing is we're creating not only those conversations, I'm having a lot of those one-on-ones. We're developing, we'll be launching in the next few months, Health Equity Connect, that is really going to be engaging our members that are health equity specific to have these conversations, but also too, really being able to see then when are we going to level set? Because this transition and all of these federal moves, they're not done. I mean, if you look at Project 2025, they're not done yet, right? So it's like really working with those member organizations in the health equity work and being able to at least just do the work and keep your head afloat. I'm a professional that worked in public health during COVID, right? You know, like did the work when it was just a 5-alarm fire. And this is beyond the 5-alarm fire because you just don't know when the next shoe is going to drop. And even having healing circles at this point, I know there's many health equity organizations that are doing that as well, that are doing that, that are really addressing those types of issues because Professionals are being impacted at the mental health level that lead health equity, and we don't really talk about that. We don't really actualize that. But we also need to be having those conversations because, yes, we're putting up a fight, but that's also impacting us too to represent our communities, our people, our investment, our priorities through the long haul. So really it's important to keep that focus in mind when we're thinking about health equity and how best to lift it.
Thank you, very insightful.
Yeah, maybe I can sort of
Yeah.
build on that. I think you make some great points. And in particular, my sense is that it's created some significant chaos in healthcare systems because you have health equity getting dragged along with anti-DEI initiatives. So initiatives that are focused on diversity in the workplace, diversity and promotion strategies and what have you, particularly in the private sector. And you have the same language of equity found in DEI, then dragging along health equity issues with it, when fundamentally health equity, which is really a form of population health, right? Understanding what the barriers that certain populations face versus other populations face. So you find that the anti-DEI fervor is then damaging the work around health equity, which is at the core of what healthcare represents. So I think the only word I can really use right now is chaos, and I think the term keeping one's head above water for these organizations is critical. You know, in our organization at Genentech and Roche, we have funded organizations who are in the patient advocacy space, and we've asked them specifically to focus on health inequities and health disparities, because we think that's an important way to advance care for all. So we have influenced the healthcare systems as well to be focusing on health equity, and now we're being asked to sort of backtrack on many of those efforts for fear of retribution against the private sector. So there's no two ways to say it other than it's created a significant amount of chaos, once again, to lean on that word, in healthcare systems and in our strategy. And I think, sometimes you'll see changing of words and terminology, but I don't think that's a sufficient approach. That doesn't keep you out of the crosshairs of an attack, per se. So I think the key is, as you suggested, doing that which is necessary to keep our heads above water, maintain adequate funding, private sector from elsewhere that can sort of keep the train on the track long enough for a sort of a return in a sort of more sensible
Or at least some
political
sort of
climate.
directive as to, we know there's so many changes, right? If a federal appropriation will come back, right? So for example, a lot of the money with CDC money, that's more prevention, right? We talk a lot about treatment, but the prevention side, a lot of that is gone. And then how do you then cover that gap, in terms of doing that? So besides just the pivot, you've still got a bunch of folks that are going to be at risk of heart disease, no matter how it is that you cut it, right? We had this prior conversation several years ago of infectious disease, COVID. The reality is the majority of Americans are going to die of this. And if you start cutting federal funding, states can't necessarily carry that cost. I worked in a state level position. There's not state appropriations to do it. There's not LHC money to do it. And there's then definitely not going to be money at the community level. So then how then do you have to do workarounds that are temporary to be able to cross bridge this is almost an impossibility, right? Because if you have people that are more sick, then they're going to go to the hospital and they're going to spend more money, right? Which is the exact opposite of the MAHA movement. So in that process, then we've got to position our professionals and those organizations that sit in that, then how then do we do these temporary fixes? How do we do these workarounds while we see how everything settles at the policy level?
Yeah, I think there's a concern that as with the Medicaid cuts, though, you've got hospitals in rural setting and urban settings that really do function at a very thin margin. So you're looking at when patients will present late, but there's really the risk that these hospitals and healthcare centers are going to shutter as a consequence. So, for what it's worth, I think it was mentioned on the previous panel to really reach out to your congresspersons and make sure they hear your voice that this degree of Medicaid cuts in specific is going to have a direct impact on the ability to deliver care, and it's going to result in the shuttering of points of care, particularly for the most vulnerable population. So this is not the time to be quiet. This is the time to make sure you reach out to those that have influence.
And
I want to also add to that, the appropriations process at the federal level is coming up. And just to emphasize that it's important for this upcoming cycle for there to be a lot of engagement with both sides of the aisle in terms of funding. The draft Trump budget dropped a couple of weeks ago, and he, for example, eliminating the HIV epidemic initiative was something he created in 2019. He proposed to zero out the dollars, so that program would no longer exist. And there's different proposals to cut, for instance, a Ryan White program to cut a portion of it that provides a lot of the oral health services, other wraparound services, technical assistance. So it is really important that stakeholders, get involved with your, as you mentioned, congressional person, but also just understanding what's happening with the appropriations process and, thinking about like how to articulate that when you cut this particular fund, this is how many jobs you're going to lose, but also how many lives you're going to also lose.
Thank you. And what you're saying is very key. For example, even next week, we're looking at the Medicaid cut where they're asking for $880 billion, and they're looking at cutting the Medicaid program. And so as we as we start to wrap up, I do want to hear from you, Janelle and Pierre, just about, as we talk about holistic approaches, can you share initiatives that your organizations are currently implementing to address many of these challenges in cardiovascular disease and generally?
Sure. So Merck has a longstanding commitment to addressing health inequities to better meet diverse needs of the populations and communities we serve. Um, we also have a very long legacy of making an impact in the cardiovascular space. And since we introduced our first therapy 60 years ago, we have remained committed to advancing innovative research to better understand and help improve the lives and improve the equity of our patients with cardiovascular disease. One of the ways that we demonstrate our commitment to health equity is through our approach to innovation. So Merck scientists right now are working on a cyclic peptide technology, which basically is to develop an orally administered drug that otherwise would have been a large molecule or a biologic. And because we determined that small molecules are better delivered and it's often cheaper to patients, and also for patients who are in rural areas or areas where they're not able to get access to or transportation to getting infusions in the doctor's offices or hospitals. We just think this is why innovation needs to be going forward in this particular space. So like with leveraging the cyclic peptide technology, again, we see it as a way to democratize patient access, broaden patient access, and also address where there's disparities and inequities. The other initiative that we have been working on in terms of like demonstrating our commitment to equity is the Merck Foundation just announced the launch of the Collaborative for Equity in Cardiac Care. It's a 5-year national initiative that it's to work to improve access to high quality, culturally responsive care for people with heart conditions living in underserved communities. Um, this initiative is committing 17 million across 5 years, so from 2025 to 2030, and this will be a multi-site initiative. So the collaborative will be focusing on addressing the needs of individuals living with coronary artery disease, stroke, heart failure, and hypertension. And really, it aims to transform the delivery of primary care by promoting person-centered approaches to meet the medical and social needs of people living with heart conditions, building sustainable community partnerships to address barriers to equitable cardiac care, improve health outcomes and quality of life for people living with heart conditions, and just doing more less sharing key learnings and lessons from this particular initiative with the community.
Thank you. And do you want to follow up on that question?
Yeah, I'll keep it straightforward for Roche and Genentech. We succeed most in reaching the community through partnerships. So it just does not make a lot of sense for a Basel, Switzerland base or South San Francisco base to pretend that it has standing in the south side of Chicago or in East Baltimore. It just doesn't make a lot of sense. So we look at our partnerships as the main way that we actually reach the community that we're trying to serve. So just give you, one or two examples that come immediately to mind. We work with a physician here in the Washington, Virginia area, Dr. Fabian Sandoval. There's a program called Tu Salud, Tu Familia, which is a TV show that's now, I think it's won 4 separate Emmy Awards, which is all about health literacy. It's about how do you boil down complicated information and present it in a way that will actually land to the population that he's trying to serve. So that's one example. The second is, okay, we are a pharmaceutical company. Our responsibility is to determine the efficacy and the safety of therapeutic interventions for patients. So we should do the research in those communities. So one of the reasons why I came to Genentech and Roche in the first place was some of the groundbreaking studies that we've done to demonstrate the efficacy of therapies in specific underserved populations. So we launched a trial focused on diabetic eye disease, for example, specifically in Black and Indigenous and Latino populations, to demonstrate the efficacy of that therapeutic in comparison to the general public. And we continue to build these, what we call post-marketing trials, that are specifically to look at populations to demonstrate that we're actually accomplishing what we intend to do with the drugs that we bring to market. So those are 2 examples of where we work through partnership, number 1, with trusted voices in the community, and number 2, we take seriously this responsibility of drug discovery and drug delivery and make sure that we do the research involving the communities where we eventually want to market and distribute our drugs.
Thank you. And so you can start making your way to ask any questions. But as we conclude, could each of you share one key takeaway on holistic approaches to addressing cardiovascular disease in medically underserved communities?
Sure, I will start. I will say my idea of a holistic approach to, solving cardiovascular disease and health inequities is really looking at some of the comorbidities, looking at how to better do more whole person care versus just a person goes into the doctor and they talk about, well, this is one condition I have, and then they don't actually look at the person and make sure like there's not, other things going on that needs to be addressed. So I think that is one area that I would say is very important. And also just, continuing to address the social determinants of health. While it's going to be really difficult in this particular landscape, I do think that this is, an area where addressing, of course, housing, transportation, food, these are things that are very important in better having people be more get better, not as sick. These are things that are very important. One last thing before I end is because I had a memory lapse about this particular issue, and I want to make sure to bring it up because it's very important. So there's a Braidwood versus Kennedy case that's going on at the Supreme Court right now. And so this is a case that is impacting the Affordable Care Act with the provision of preventive services. So right now that they're deliberating on whether these preventive services can continue to be offered at $0 cost share. So right now, when you go into a commercial plan or a Medicaid expansion plan, and you get a screening for, heart disease, or you get a screening for diabetes, usually you don't pay anything for those screenings. Well, with this particular court case, if it goes the way of the plaintiffs, it would mean that the USPSTF, United States Preventative Task Force, the officers that deliberate and think about all these different recommendations for preventive screenings, they're saying like they're not appointed by the secretary, and so because of these recommendations that were developed from back to 2010, they will no longer apply, and so health plans will then have the flexibility, or they want to choose to incorporate more cost sharing on some of these preventive services. So that's why this particular case is very important, and I wanted to highlight it because it's going on right now at the Supreme Court, and there should be a decision by next month. But it does have tremendous impact on the access and screening issues in the cardiovascular space.
Okay. Would you like to leave us with one takeaway? Well,
Yeah, I'm a physician at core, sort of, wearing the suit of a business person, but really at the core of what I do is really trying to take care of patients and make sure they're well. So I'll leave you with a couple thoughts from that perspective. The first, sort of a shout out to my American Heart Association colleagues and ABC colleagues as well. And online there is a risk calculator called the Prevent Calculator at the AHA website. If you go there, it will show you what are the modifiable risk factors for cardiovascular disease. Run through the test yourself. It'll give you a score as to whether you're high, medium, or low risk for cardiovascular disease. From a personal standpoint, it's helpful. But also understand what those elements are, those core risk factors, so you can communicate them, at the barbecue and at the church and, at the barbershop. Can you actually speak to those core risk factors? So that's one sort of simple thing that I would recommend. And the other is, and I said it earlier, but I think it's reasonable if you don't know who your congressperson is in your district, find out who that congressperson is in your district and, go to their website and leave a note about these issues, because I do think it matters. You have access at that congressional level and at the local level as well in your individual states. Make sure your voice is being heard. It's so easy right now to feel disempowered. It may seem like a small thing, but as a collective, our voices coming together do matter and do influence policies. So an individual thing and then sort of a more policy-oriented recommendation.
great.
So I would build off Pierre. I mean, I think that part of that too is the advocacy part. I have done advocacy days with numerous public health organizations, and you would be surprised that, knowledge gap of lack of understanding when it comes to prevention, screening, basic health promotion, health education. And so just being able to tell your lived experience, we already had a panelist in the prior panel here speak to that. I'm also going through that right now with my son and, meeting with a member of Congress for his story. So relevant, so important. But I think particularly when it comes to cardiovascular disease, I think it's thinking, how is it now that we are going to pivot? How is it now that we are going to have to invent? Because I think that for some professions, so I belong to public health, very invested American Public Health Association. I believe Georges Benjamin is going to be in the back of the room. And I'm in a volunteer leader position for that organization. Where do we sit now at the crux where we have a loss of revenue? And what do we do with that workforce, right? Because many people in that workforce are diabetes educators, work in the cardiovascular landscape, work in local health departments, work in organizations. Most organizations are going to overlap with chronic disease anyway, some way, somehow. How is it then that we use our workforce that we have? Because the message right now is maybe you should pivot. The problem is if you study public health, you're not necessarily going to go into IT unless that's your specialty, right? So the pivoting process, I think, is going to be key, because if we lose these professionals, it's going to take us a day, 2 days, 3 times as much work to bring them back into the workforce. Oftentimes, these are professionals who are very well versed in our communities, are very well versed in clinical care, and that's important. The other part, too, that we haven't really talked about, we've talked about clinical trials. One of my specialty areas is also community-based participatory research, is then that other side of academia that we've lost in terms of funding, because not all research is only clinical trials. Community-based participatory research may be, how can we engage a community for them to understand cardiovascular risk? How do we engage a community, for example, that has never had access to how best we can do that? Many of those programs have also been disinvested. So then without that academic bucket and those academicians, how do we keep them in the fold? Because those individuals may not necessarily want to say, hey, I can jump from this to that, when my passion project is making sure that wellness and investment at the community-based level is kept. And this is my professional approach within my career trajectory. So we have workforce as an aspect, we have access to care, we have the role of policy, but also then how do we integrate that to then readjust, because we don't want these entire career pathways to disappear because there's no longer the federal investment. And we really have to keep that in mind, that although we have strong business and industry partners, they will always be there in partnership. We also have to include the federal government in this conversation in this new iteration of what the federal government will look like, but also making sure that they don't ignore the needs of our populations, because that's not going to necessarily go away. And all of that infrastructure and capacity that it's taken us so long to build is not necessarily an investment that we should just push out the door. So those are my closing comments.
And if there are any questions, please feel free to come to the microphone. But as we conclude, we've heard partnerships, trusted voices, health literacy, also efficacy and metrics. We've heard social determinants of health. We also heard, which is very important, about the Braidwood case that's coming down around the USPSTF. We've also heard policy as a driver for change and really elevating voices. And so the real impact happens when we work directly with communities, formulating ideas, creating plans and programs to create solutions that address these disparities. If there are not any, I don't know if there are questions. Oh, sorry, there's one question. Okay.
Hi, Camille Campbell with Acclinate. So we talked a lot about policy, and we know that there is the Make America Healthy Again movement, but we also just talked about how a lot of the other things that are happening within the government are contradictory to actually making America healthy again, and will be detrimental from a chronic disease, cardiovascular disease space. And we also talked about the impact that we can have by calling and talking to our Congress people ourselves. I'm curious, from an industry perspective, our industry partners on the stage, can you tell us a bit about the collective response from industry to the government, seeing as how industry is very influential? And this may have been a better question for Courtney Christian, but I don't see her in the room, so I'd love to hear your thoughts.
I'll start first. At Merck, I think we call it full steam ahead. We are still focused on our priorities around access and affordability for patients. We are, still focused on, a lot of our strategies around diversity and inclusion. We recognize that, yes, it's a very difficult federal policy landscape, and there are, particular challenges that we are also going to be facing with maybe the incoming tariffs on pharmaceuticals. But we recognize that we, continue to have a role in addressing, patient needs, and also improving access, and just making sure that we can continue innovation in a lot of the chronic diseases and all this, other therapeutic areas. So I would say, it's still full steam ahead. It's just that I'm going to tell you, I have a big spreadsheet in my, every day I'm having to update what's happening with this executive order, this particular issue, but we are trying to make sure, we can understand what's happening, and also, how we can, develop strategies to either, try to work within what we're seeing, but also, how we can think about improvements for the future.
Yeah, I just would add on top of that, by the way, big fan of what Acclinate does, is that I would say that from an industry perspective, we shouldn't see ourselves as individual actors, because one of the strategies is to make each individual feel at risk and each organization feel at risk, and therefore no individual organization is willing to stand up and really push back. When we actually come together as a collective, and we do that through a couple of the trade organizations, pharma and bio in specific, then we have the capacity as a collective voice across industry. So it's not just Genentech or J&J or Merck or GSK or whomever, but it's a collective group. And so that is currently being assembled, but that's another place where we can influence, and actually each of the individuals in this room can influence through those larger organizations, bringing your voice there to kind of push industry to work as a collective.
And we are at time, and I want to say thank you to our panelists, Janelle Gillings, Dr. Pierre Theodore, and Dr. Miss Eric Cuevas. Thank you so much for your insightful.
Oh, thank you.
Blue Cross and Blue Shield companies believe healthy communities start with healthy moms and babies. That's why we're advocating for better care at every stage of pregnancy. We're working to ensure moms have access to the care they need at a price they can afford. We're embracing the vital role of doulas, midwives, and community health workers. We're expanding the workforce to support the next generation of care providers. We're determined to create a better system of health, one that is built on trust, one that supports healthier families for generations to come.
After. Thank you so much. Welcome, everyone. We are delighted to begin our next session. Intersectional Identity, Raising Visibility and Data Prioritization. We are delighted that you are here with us. Friends, equitable data standards cannot be achieved without data that accurately reflects the complexities of race, ethnicity, language, sexual orientation, gender identification, socioeconomic status, and disabilities. We are concerned that data collection methods may fail to capture intersectional experiences, reinforcing systemic invisibility and exacerbating health disparities, resulting in the misclassification and erasure of diverse identities. We want everyone in this room to be seen. We want you to be seen. Welcome to our panel. My name is Courtney Lang. I am honored to serve as your moderator. I run a health justice public affairs firm based in Washington, D.C. I'm going to begin by briefly introducing or announcing our esteemed panel, but I would be remiss if I did not first acknowledge the work of the Data Equity Coalition, co-convened and co-founded by the National Minority Equality Forum and Blue Cross Blue Shield Association. I want to thank Gretchen Wortman, Dr. Gary Puckrin, Aishat Magbade, and David Merritt, and the late Keisha Brooks Coley. Thank you so much. To my left, Dr. Carla Alvarado, Director of Research, AAMC Center for Health Justice, Mary L. Smith, Vice President and Managing Director of the Asian Pacific Islander American Health Forum and the former CEO of the Indian Health Services. Dr. Georges Benjamin, Healthcare Luminary, and Executive Director of the American Public Health Association. Denise Schofield, Executive Director of Enterprise Data Strategy and Systems, Blue Cross Blue Shield Association. Join me in providing a warm welcome to our panel. Thank you. Well, Dr. Benjamin, I wanted to begin with you because of the nature of our current political environment, which has been alluded to a number of times this morning. And so in light of recent attacks, erasures, retraction around data sets, can you please share with the audience why protecting and preserving data and raising visibility is critical to public health?
Thanks, Courtney. Obviously, knowing where to focus. If you had unlimited resources, you would still want to focus your work. And data-driven decision-making is only accomplished if you have facts. And so getting the data is extraordinarily important in order for you to be able to do that. But I'm going to tell you one story, because there's always this issue about who benefits. And the fact of the matter is, everyone benefits when you do that kind of data-driven decision-making. Many years ago, I was working for the state of Maryland, and we had an infant mortality outbreak. Health departments love to measure infant mortality, and of course, this year infant mortality went up. It went up in a population we weren't expecting it to. It went up in basically middle-class, well-insured African-American women. And the question was why? And we looked into it, and it was because these women were now having access to fertility treatment. More fertility treatment, smaller babies, higher infant mortality rate. And for whatever reason, they were not necessarily caring for by people that were more skilled in doing that because the technology was, was easy to now get, and they were not being managed as high-risk pregnancies. So, and of course, it was a pretty broad increase, stayed around for a long period of time during that particular year. We did a look back, and it turned out we had missed the same phenomenon in white women. So the broader population benefited because we saw this spike in a population that was theoretically more at risk, although they had the same, insurance status, middle class, in a state that was very much focused on universal health care. So everyone benefits. So don't allow anyone to tell you that somehow doing diversity, equity, inclusion is stigmatizing, is discriminatory. It is not.
Exactly. Exactly. Important distinctions to make. And Denise, I know that in our work together with the Data Equity Coalition, your leadership around data systems and governance has provided very much a lens to some of the facts that Dr. Benjamin has shared. I wanted to see if you could help to provide the audience with context on the Data Equity Coalition, our work as advocates around SPD 15, the Office of Management and Budget, how we got here. If you could just help provide a little bit of the background on that and the significance to healthcare stakeholders.
So SPD 15, or Statistical Policy Directive 15, was actually established in the late 70s by the Office of Management and Budget, specifically for the purpose of standardizing the framework by which race and ethnicity data are collected. The rationale behind creating that was to ensure that there was consistency and comparability across federal agencies when it came to resource allocation, policy analysis, thinking about things like civil rights enforcement, legislative compliance. So think back to the late 70s, 1977, long time ago. There were 5 categories of race that were identified as part of the standardized framework. Fast forward to 1997, the first of 2 changes that have happened to SPD 15, and we saw the race and ethnicity questions get separated. So we had 5 categories of race, 2 categories of ethnicity. Fast forward to 2020, and you look at what happened relative to the COVID-19 pandemic, what happened in terms of the social unrest and the civil injustices that were taking place in our country. And there was a push for taking a look at SPD 15 and saying, does this really reflect who we are as a nation? Does it capture our diversity? And if we're not capturing the diversity, how are we going to address health disparities? So through the work of the Data Equity Coalition, we advocated and participated in the public commentary process around the changes that got approved in April of 2024. So now we have combined the questions back again. So there's one question around race and ethnicity, and that will hopefully reduce some of the confusion around how people actually answered that. There is a belief that there's underrepresentation of some of the categories given that 2-question format. Now it's 1 question. They've added Middle Eastern and Northern African as a racial category, and underneath each racial domain, there are disaggregated options to choose from. So for example, if I choose Hispanic, I could say Hispanic Mexican versus Hispanic Cuban versus Hispanic Puerto Rican. And that's important because not all Hispanics are monoliths. Not all African Americans are monoliths. It is important to understand and go deeper on the disaggregated data to really help to address health inequities. And the importance of SPD 15 cannot be understated when it comes to being able to your point, Courtney, to see what's happening. Because if we can't see it, we can't measure it. If we can't measure it, we can't address it. And if we can't address it, there's no accountability. So it is critically important that we keep advocating for the implementation of SPD 15.
Thank you. So audience, please make sure that you commit to memory. Statistical Policy Directive 15. We need everyone to empower their advocacy education around SPD 15. Carla, given the significance and in the work that you do at AAMC around asset-based and intersectional frameworks around research and policy, can you just define, when we're talking about intersectionality, what does that mean?
Well, it has a very rich history, and I hope I do it some justice. So as you know, the term itself, Kimberly Crenshaw coined it back in 1989, and it does have its conceptual formation dating back to anti-slavery, anti-colonial, post-colonial studies. And so at the very core of it, we know that intersectionality arose from the exclusion of women in the civil rights movement and the exclusion of women of color in the feminist movement during the civil rights era. And so at its very core, it's maybe made up of 4 fundamental tenets that we need to understand. That the identities that we inhabit are multiple, simultaneous, and mutually constitutive, such that they exist at the same time, they form and conform one to one another, and these identities have positions of advantage and disadvantage. Just think of any social category and you'll immediately think of the socially disadvantaged position within it. And these positions of advantage and disadvantage within these identities are important because they denote positions of power, and they also describe the processes of discrimination that arise from them. Yeah. And so historically, we know that people have been oppressed and suppressed, and intersectionality talks about systems of oppression that perpetuate themselves. And that's why we see that we cannot quite get out of this oppression that we seem to recreate for ourselves. And when we talk about intersectionality, we have to notice the trinity of gender, race, and class. So it is not enough to only name a couple of intersections and call that intersectionality. A lot of the times we only think of the social positions of disadvantage when we think about intersectionality, and that's actually multiple jeopardy, double jeopardy. And so let's not disparage the concept of intersectionality, because it also talks about the power structure and power dynamics, and that no one is powerless completely and absolutely, and no one is completely powerful and absolutely. So in that sense, we need to take what we've heard here about partnership and collaboration and collective action, in that we do have power. So thank you.
Thank you. Yes, the power, oppression versus suppression. I love that. And we're not checking just one box, friends. We are checking multiple boxes. We present every single day with multiple identities. Mary, you are perfectly suited to be able to give us perspective on why intersectional identification and data collection are so powerful to health policy, and making sure that we are driving our data leadership with health policy and outcomes from the perspective of the communities that you have just so fearlessly represented. Thank you.
Well, good morning, everyone. It's great to be here. This is such an important topic, and it's kind of fitting that we're here a little over 5 years since COVID started, and probably all of us were in the trenches during that time. And I work at the Asian and Pacific Islander American Health Forum. I'm obviously not Asian, I'm actually Native American, but if you all remember, like back to the early days of the pandemic when the vaccines were just first available, and they were very small, limited quantities, so there were very tight criteria for who could get the vaccine. And initially, they started with the first wave of people, I think, over 65. And some of our partners at the Health Forum, you know, we represent the Asian American, which is not monolithic, but also Native Hawaiians and Pacific Islanders. And people from the Native Hawaiian and Pacific Islander communities said, you know what? That doesn't work for us because most of our people don't even live to be 65. So our elders are not even 65. So it's thinking about things like that. And you know, we know through the social determinants of health too, how education, healthcare, transportation, housing all impact I had a recent story. I was at a university trying to help them attract more Native American students. And, you know, I think what we're seeing is intersectionality is only on the rise. I think very few people now check one box. And at this university, it's just a matter of educating people. And you all here, we're the educators, I think, because most of the Native American students at that university, most of them, that particular university, also checked Hispanic. And some of the administrators who are not very familiar, they said, oh, okay, we probably don't need to do Native outreach. We'll just put them in the Hispanic category. And you can't, that's why education is so important, because yeah, it's crazy. So it's very important in the health context. And I know I'll just final story about Asians. I think a lot of people, they look at the educational statistics and say, oh, you know, Asian Americans are doing better than African Americans, Native Americans, Hispanic in education. They're probably well educated, better off. Well, there's so many different parts of the Asian community. A lot of them are immigrants. A lot of them are, you know, on the poverty line. And in health statistics, if you looked at the data collectively, overall, Asians have a longer lifespan. But if you break it down, like American Samoa and Native Hawaiians actually are less than the average. So it's very important to break down the data.
We must break down the data, and that is core to our advocacy. Dr. Benjamin, in the last few days, we have seen some restrictions to potentially hit the medical community, that we're concerned about some of the executive orders that are impacting medicine in particular. But we wanted to hear from you on why is making representation, visibility, so key to a patient's ability to receive treatment, to get access, to receive care, to navigate the healthcare system. Why does representation and their individual visibility matter?
You know, one of the things that I learned very early on in medicine was that medicine is both an art and a science. And the art form, of course, is driven by a lot of things. See one before, you're more likely to think about it. But life experience as a clinician is extraordinarily important, where you come from and what you see. My favorite misnomer in medicine is this patient is non-compliant. You know, Mr. Jones comes in, his blood pressure is always high, and you know, the physician that has learned from one community's life experience, their own, may not really understand why Mr. Jones' blood pressure is always high. They given Mr. Jones a diet, and they've manipulated his medications every time he comes in. And, you know, last time he came in, they added some water pills because he's a little salt overloaded, and et cetera, et cetera, et cetera. But if they had the same life experience that Mr. Jones had, they're likely to understand that Mr. Jones doesn't cook for himself. He's of the generation where his spouse cooks for him. And because of where they grew up, they cook highly salted foods. So the person that you need to be talking to is not Mr. Jones. You need to be talking to the cook. And the challenge is that labeling him as non-compliant isn't very productive, is derogatory, but it hasn't solved the problem. And the only reason you thought about it is because you grew up in the same kind of household.
Yes.
You had the same life experience. It is very, very important to do that. Doesn't mean that all of us can't learn from other people's life experiences, but where that happens, when I was in medical school, was me sitting around talking to my other colleagues who also had different life experiences than I did, and sharing stories, doing case presentations at Morning Report, and being asked in front of my colleagues different questions and being challenged by people with different life experiences. That's why diversity is so extraordinarily important, in the training experience, because again, diverse education delivers diverse providers who provide better care for all.
There it is. That's right. We must protect our healthcare workforce at all costs. Denise, I wanted to piggyback off of that. How does the failure to collect equitable data standards actually harm the healthcare ecosystem? How is it harmful if we don't collect data?
Short answer is it can be very harmful because without the data and without understanding where the health disparities are and what the causes are, in particular intersectionality data, right? So the intersection identities of an individual. How is it that we're able then to create interventions that actually help those populations? So take a Hispanic individual who identifies as LGBTQ, part of that community. They're experiencing discrimination and systemic inequities associated with both of those things. And if we just consider that one person Hispanic or part of the LGBTQ community, we are not recognizing how those two challenges come together. And we are not necessarily able then to identify interventions that are actually going to help that individual. The lack of the data washes away that diversity that is so important to see in order to create those interventions that matter. Underrepresentation is another byproduct of not having the data, and that can lead to poor health outcomes. It can lead to increased disparities over time. So it's really important that we have the disaggregated data.
So we have seen a bit of attack on data sets, data research, potentially being compromised. It has been alluded to earlier this morning. And Carla, Dr. Alvarado, I wanted to know if you could help us to kind of clarify why research and sort of preserving the historical importance of research, how that helps to implement and have us adopt new data standards. If it's wiped away, kind of what's that impact? And where do we go from here to help to really continue to galvanize our research community?
I think in terms of, we were getting to the point where we were talking about evidence-based policy.
Yes.
And that evidence-based policy, first of all, is a misnomer. It's an oxymoron because, as you can see, all of these policies that are being instituted fail to follow the evidence. And so, first and foremost, that research that we've built, going back to intersectionality, in a way has been erroneous. We've been focused on race-based analyses for about 40, 50 years, and that hasn't done much for health disparities, health inequities. And so acknowledging intersectionality and just having that beginning of, we have the data available to start then looking at the data that's always been there, but through this lens of intersectionality, that intersectionality told us, if you look at race-based analyses, if you only look at single factor lives, you are creating invisible minorities. And that has happened with a multiracial group, which we do not have information on. Again, because going back to this framework. And so to answer your question, it's that research that we had been building, that progress that we had been making, right now we're in a survival mode because the democratization of data that had happened with public use files available, because the taxpayers are funding this, that we had a right to, are being suppressed and deleted. And so we are what Dr. Echohawk has called data genocide.
That's right.
And so we're at that point where we are looking at erasure of progress, erasure of people, erasure of identities. And so I'll leave it there.
Well, that's probably the most powerful statement, right? Data genocide. Yeah, Mary, do you have a follow-up on that?
Oh, yeah. I mean, it's so important. I mean, just being Native Americans have been a race since the beginning of this country.
Exactly.
And I think the thing that's really why this panel is so timely is we're in a period where we've made a lot of progress, but as the doctor mentioned, we still have a ways to go.
Mhm.
And then we're having these efforts to try to roll back the progress. And it's at the juncture of so many things that are happening simultaneously. Like by 2040, we're going to be a minority majority population. So we're not going anywhere. We're here. We're not invisible. And then we see the use of artificial intelligence in medicine, which artificial intelligence is only as good as the data that's input into it. So we're at a juncture where, you know, as Denise mentioned, interventions could be seriously harmful if the proper data is not inputted. So it is extremely important, and I think if all of us walk away from this room like trying to do what we can, because we see what's happening at the federal level, but at the state level, I know a lot of state public health departments just don't even have the funding. And the one thing that I think disheartens me is, and I would love thoughts of everyone in the room, is that, you know, I think at the beginning of the pandemic, as awful as it was, I thought, oh, we'll be better prepared. We'll have better public health infrastructure. And I honestly think we're actually kind of worse off. And so we are starting a little bit behind. And so all of us, I think, need to be advocates and warriors out there for the importance of this going forward.
We must protect the data. If you have been watching the news, you have seen that measles is on the rise. You know, we had essentially eradicated the measles epidemic in the US, and the measles is on the rise. We have pneumococcal disease that's on the rise. We have a number of areas that are on the rise. And I want to acknowledge the work of the American Public Health Association, that in light of all of the attacks that have occurred, there is great comfort that we feel in knowing that public health continues to stand for people in community. So I wanted to acknowledge that, Dr. Benjamin, and just ask, what can we do to continue to collaborate, support you with your advocacy for data, research, preservation, protecting our public health?
You know, tragically, the administration has stopped, as you know, legally, they stopped, well, illegally, they stopped many of the grants. They did it in an illegal manner, particularly grants focused on diversity, equity, and inclusion, confounding affirmative action, which the Supreme Court has ruled on, with DEI, with health equity, and they keep moving the football every time they have a conversation. We can talk about their motives later, but well, it's racist. Let's be clear about what they're doing.
Yeah. There it is.
But, you know, and anyone who doesn't understand that has got their head in the sand. And the truth of the matter is that we have, along with other groups, have sued them to require that they begin to reestablish those grants. And we think that's important. And our strategy has been, A, make them follow the law, because most of what they're doing is illegal or being done in an illegal manner. Number two, focusing like a laser on things we think are going to be important. So they're doing a lot of stuff. The flood the zone strategy is so you can't find the football, right?
That's right.
But being an ER doc, I know how to triage. We can find the football. I know exactly where it's going to be.
There it is.
And so it's money, personnel, structure. And we've tried to legally address all three of those things through our advocacy strategy. Next thing we're trying to do is make sure that we hold them accountable. That means telling people what they're doing. One of the challenges we have is people don't know how it's affecting them.
Yes.
So making sure that people understand that their water may not be safe to drink, their food may not be safe to eat. By defining what public health does from a practical perspective, that access to care is at risk, particularly right now, the Medicaid. Congress is now back. They're
Mhm.
about to cut the Medicaid budget. They want $880 billion out of the Medicaid program. Money for underserved people, long-term care folks, et cetera. Again, everybody's at risk because most of the Medicaid money actually goes for long-term care. And so we just want to make sure people understand that. And then finally, to the extent we can not do anticipatory agreement with them. And what that means is when they said DEI was bad, people ran for the hills and said, oh my God, DEI is bad. We have to come up with some new words. And I'm arguing don't do that. There's nothing wrong with diversity, equity, and inclusion. We had a civil war on it. We had a 13th, 14th, and 15th Amendment put in our Constitution over it. And to tell an African-American male that there's something wrong with that ain't going to happen. So I would argue that we should not do anticipatory capitulation to them. And you can look it up. It's actually a phrase, and we should not do that. And so I think those are going to be very important things that we do as we go forward. The intersectionality of all of these things come together in many ways, and you know, the nation's at a point of nation that we just have to push back, and we cannot push back the way we used to. Writing letters is one form of voicing your opinion, and you should do that. Making phone calls is another one. But, you know, civil disobedience was done in the 60s, and my view is it's time for that again.
Anticipatory capitulation, a term that everyone in this room should know. I believe the Center for Health Justice has some work reflection. We do acknowledge that the Center for Disease Control and Prevention under the prior administration did acknowledge that racism is a public health threat. We would also argue that the failure to honor representation is also a public health threat. Carla, just wanted to provide you with opportunity to comment on the work of the center.
Right, so at the center, we focus on community engaged research. And I think throughout the summit, we've heard community collaboration, trust, partnerships over and over again. And the center focuses on that as its leverage point. We have a multi-sector partner group. As the name denotes, different sectors represent and inform the work that we do as a quasi-advisory council. And we lean on a charge group, which is a collaborative for research and action, made up of about 1,700 people from across the spectrum, from industry, academia, to nonprofits, to community-based organizations, grassroots, pharma included. So we lean on the community wisdom and then community engagement. And I think at this point, that's what's going to move us forward, or at least keep us afloat. It's going to be that lifesaver for us. Let's think about those partnerships. Let's think about citizen scientists. Let's think about, yesterday in our last panel with the environmental justice, we saw how two individuals were very instrumental in collecting data at the local level. So then looking now the leverage of the local politics, of the local and state levers that we can pull to collect the data that we're going to need to move forward. And so community engagement will be of the utmost importance moving forward when it comes to research and data and keeping afloat.
Thank you. I appreciate that, because we're trying to really dial down on why you can't separate your advocacy from data research. You can never compromise data equity when at the core, it is the foundation of our health equity movement. Denise, you gave a definition of SPD 15. Could you also just share a little bit about the research that you are diving into specifically, and what types of advancements around intersectional data equity do you see as most important to continue this movement, this mission?
So the work that we're undertaking now, and this has been an evolution over the last 3 years, is really looking at what does it take for an individual to want to share that type of information. These are very personal things about ourselves. And when we think about the fact that we need the data, we can have all the standardized frameworks that we want, but if people aren't willing to share that information, and we know self-reported is the gold standard, how do we get it? And so the research that we've done is really taking it from an individual perspective, understanding from an individual perspective, what is the decision-making model they go through when deciding whether to provide that information. Thinking about their lived experiences, thinking about what challenges it may present for them personally, thinking about the context in which the questions are being asked, thinking about who's asking the questions. All of these things are incredibly important to creating something that an individual will want to respond to. And what we've learned in our research, which is initially focused on race and ethnicity and thinking about how that impacts your willingness to share information, is that there are a lot of challenges we have to overcome. We have to provide evidence that what we say we're going to do with the data is actually what we do with the data. We have to provide evidence that there's going to be benefits both to the individual and to their community. And all of these things help in design principles when you're thinking about actually collecting the information. Where we're going next is looking at how intersectionality impacts an individual's willingness. So again, taking it from the individual's point of view to understand what does it take to be a co-creator of getting that information? What does it take to be a trusted, responsible party using that information? And how do we demonstrate that we did what we said we were going to do with the data and nothing more? And so that's a research that we're undertaking now from an individual's perspective.
That's super important. I think building trust in community, we've seen that in many of the sessions around sort of that lack of trust at the community level, how it really impacts people's ability to feel like the healthcare ecosystem is working in their best interests. Mary, Asian Pacific Islander American Health Forum has been working not just at the federal level, right, but at the state and local level as well, and was hoping that you could illustrate for the audience how federal impacts the state and local in a way that really helps to kind of build community, and how that trust factor is really essential to making sure that we're not leaving anyone behind, but we're pulling everybody forward in a progressive way that it seeks to empower individuals.
Now that's so important. I know we're talking about SPD 15 here and the work of OMB, but actually at the Health Forum, I know Denise kind of went through the history, and there were many years there were no changes. And one of our funders at that point thought, nothing's going to happen at the federal level. So they funded a project where we worked on data disaggregation in several states. And it is so important. I think both of those systems, federal and state, complement each other. We did work in California, Nevada, Michigan, among others. And like, for instance, Nevada is very interesting because most of the communities of color live all in one county, live in Clark County, not the rest of the state. So it's very important to have that disaggregated data, or you're not going to be getting a complete picture. And really the federal and the state data complement each other and reinforce each other, so that you don't get inaccurate data and you don't get that invisibility that the panel has talked about already.
Exactly. We have talked a little bit about SPD 15, Statistical Policy Directive 15, focused exclusively on race and ethnicity, though our advocacy focused on language inclusivity, as well as gender, sexual orientation, and gender identification. We haven't really delved into that. There have been some erasures as it relates to SOGI in particular, very specific erasures of SOGI, in addition to a retraction when it comes to reproductive autonomy. Dr. Benjamin, I wanted to see if you could help to amplify why protecting SOGI data is really so critical to the advancement of public health and really what happens at the state and local level when we don't actually count SOGI data.
Yeah, the challenge we have when we don't deal with people who are LGBTQ, people with disabilities, and we don't capture that data and better understand what their needs are. You don't put systems in place to deal with it. We have failed as a nation on language so badly. Just think about it. So I spent the first half of my career practicing emergency medicine, actually. And the number of times I'm in an emergency department where I have a 12-year-old kid, sometimes a little younger, translating for his or her mom or sister, coming in basically with a vaginal bleeding, a reproductive health issue, even abdominal pain. And this 12-year-old is now, because I didn't speak Spanish, and this kid is now translating. Boy, what a very difficult situation you put that young person in. Asking questions around her mom's or family members' reproductive history. Imagine what happens when that person also is disabled, is in a wheelchair.
That's it.
Or is somehow also immobile, and you having to ask questions about their disability. And, sometimes that's a very sensitive topic for some folks. Sexual orientation, again, is a big issue where lots of sensitivity needs to be had. And you need to understand how to ask those questions. You need to understand what the risk factors are. If you don't know that you have to ask whether or not this is an individual, a male who has sex with men, you're going to miss something. If you don't understand this individual's bisexual, you're going to miss something. Imagine what do you do when you're asking that question and you're now making assumptions about them. What do you do when a person comes in who's a priest, who's got AIDS, who is gay, and you're now making a range of assumptions about that individual because you don't understand what the incidence of a particular disease in that population is in your community?
Yes.
I mean, we all make assumptions about folks all the time based on what we see.
That's right.
We all walk in that room with biases.
That's right.
And those biases only get informed when you have the data that you've gotten that tells you that this particular population is more at risk
That's right.
than another population. Now, you may still miss it because the data doesn't capture it, as I talked about with the infant mortality story earlier. But you're definitely going to miss it if you don't ask the question.
The data always matters.
Data always matters.
Always matters. I'm going to invite you to come to the microphone if you have questions. But before I take the Q&A, I want to address language. We must address language. I know we had a pre-call and we were talking about language and linguistic data, competency, access, advocacy, what it means. Mary and Carla, I would be remiss if you all did not comment on the importance of language in our data advocacy.
Yeah, that is actually one of the major areas that the Health Forum works on, because like I said, we represent the Asian American, Native Hawaiian, and Pacific Islander community. And I keep going back to COVID because I think as Dr. Benjamin can appreciate, that's one of the largest public health catastrophes that we've had recently. And during that, which, this is something else Dr. Benjamin mentioned, a lot of the grants are no longer there, but during COVID, we were one of the main funders for the Asian community from the CDC, and we were translating everything in over 35 languages, and actually that still was not enough.
Not enough.
And in fact, a couple times, the CDC asked us for our materials because they weren't translating in the languages that we had translated in for the Asian American, Native Hawaiian, and Pacific Islander community. So language access is so important in terms of public health education, as the doctor mentioned, the doctor-patient relationship,
Yes.
everywhere.
Yeah, amen to that, including American Sign Language, which we often leave out, including American Sign Language. Carla, please.
And just to talk about even the, we talk about, for example, health literacy and how language plays into that. Even if things are translated, it doesn't mean that they're at the level.
That's right.
That people need for understanding.
For understanding.
And so the legality of having people sign documents that they literally can see the words are in Spanish but cannot understand. I wonder why the medical community or the medical legal community hasn't looked at, people are signing things they don't know they're signing and they don't know what they mean. And so that is to say that, of course, language is first and foremost, but I think it's one of the oldest fights, if you will, that we've had. And just looking at where we stand, it's dismal and it's about to get worse. And so if there is anything that we have to integrate in this intersectional framework that we're looking at is language and health literacy as a component, and health literacy that is on the onus of the health system and not placed on the shoulders of the patient, where they have to become literate to understand. It's no, we have to learn to communicate with them.
That's
right. And so, thank you.
No, that's right. And just to illuminate what you all have shared about language, there's a difference between translation and interpretation. Oftentimes, we will have medical and healthcare information translated, wrong grade level, not well understood, needs to be third grade or less. And then we overlook, we need an interpreter, right? Interpretation. So really key points, inviting people to the panel. I know I had some individuals who had asked some questions before we even had this panel. And so, yeah, Dr. Benjamin.
Let me add one other thing. You know, my kids make me watch Facebook, so I see all these things that where people are telling people that they need to speak English. And remind you, I mean, obviously English is certainly a very important language in our nation. But just remind you, for most of our nation's history, English was not the language of choice for most of our residents here, right? And for this continent, it absolutely was not the language of choice. I mean, when this nation was founded, we spoke French, English, Spanish, Dutch, I'm sure there are others that I can't. Oh, and of course, all the Native American languages that were prevalent on this continent. And for most of this nation, which certainly most of the West was part of Spain, we spoke Spanish or one of the Native American languages. So I think we ought to recognize the enormous diversity of the way we communicate in our country, both dialects, et cetera. And while English is clearly the centerpiece of our way of communicating, far too many people don't. And we also need to recognize that as a nation, we have failed in the literacy area. So far too many people are unable to communicate, even at basic, English levels.
That's right. So, friends, I want to take a moment for Q&A. Thank you. We're going to circle back to the panel for a final thought, but I wanted to take questions from the audience. I'm going to start over here with, if you're a part of the Data Equity Coalition or you've visited the Data Equity Coalition, you're like a friend of the Data Equity Coalition, can you raise your hand? Because y'all are in the room. I see you. Yeah, I see about, okay. All are welcome to join the Data Equity Coalition. We appreciate your advocacy for SPD 15 and beyond and intersectional identification. Thank you so much, Brian.
So I'm Brian Davis with the Leukemia and Lymphoma Society, and my question for the panel is, what can patients do beyond federal policy to engage broader healthcare ecosystem in sustaining real SOGI data standards.
Okay. What can patients do? Real quick, like 30 seconds, we just go right down. Carla.
Self-advocate and know what at least the law for now protects. And I think the hospitals need to do a better job at displaying what the patient rights are in different languages, such that when they're waiting, they can advocate for themselves. It's a just-in-time kind of quick training. Look at what you're eligible for, look at the translation, at the interpretation, at the fact that you have the right to receive the information in written form, right? And so just self-advocate, but that takes education on our part.
Thank you. I'm going to bounce down here to Denise. Is there a thought on what patients can do for REL and SOGI? Yeah.
In addition to self-advocating, I think also finding others in your community who have similar issues.
That's
I've
good.
heard a lot about community, a lot about collaboration, a lot about advocacy. I think all those things together can help an individual make a difference in getting what they need from the healthcare system. So I would just say adding some, finding like-minded folks within your community and really kind of taking a grassroots approach to your advocacy would be helpful.
Perfect. Perfect. I'm going to take this question and then, okay.
So I'm Carlos Ferrance. I'm from UCLA. I think a lot about data disaggregation, so I really appreciate this panel.
Yeah.
I know New York and California have some laws on the books that promote data disaggregation, but I'm wondering if you guys know of any other states that have great examples of pending legislation that would codify SPD 15.
Great question. States on data disaggregation, legislation pending, Center for Health Justice. Do you guys keep a list of the states?
Not a list of the states so much, but I know, for example, Oregon is very progressive in the identification and disaggregation of data. However, Oregon is predominantly white.
Right.
And so then you run into problems of generalizability, et cetera, when you're doing quantitative analyses. And so there comes that point when you're doing research.
Does public health keep that
We
legislation?
don't.
We track, okay.
We're not tracking.
We're not tracking. Is a BCBSA tracking state level?
I don't think so, but just to follow up to what Carlos said, I also think Colorado might be another state that's looking at doing some of that same work on disaggregating data.
Okay, so Oregon, Colorado in addition. Okay, good to know. Mary, do you all track that?
We worked on that project, but just like you said, California had passed a law to disaggregate in the Asian community a few years back, and New York was working on it, but I'm not aware of like more recent efforts in other states.
So that's a good project. That's a homework. That's a homework assignment. We need to figure out the states, and then that's a good kind of takeaway on data disaggregation at the state level. So that's our homework. Yes, Dr. McDade.
Bill McDade from ACGME. I look at the presidential executive orders, and you look at the playbook for the executive orders that the Cato Institute, a libertarian think tank, put out. And they actually say that because executive orders can be reversed, that in fact the reestablishment of affirmative action on the race-based policies by a future administration will require data to be classified as relevant racial categories. If that future administration had a head start from scratch in data collection, it would delay the implementation of such policies by years and significantly raise the cost in doing so. And further, government data on race and ethnicity provides evidence or even the impetus but for different racial and ethnic groups to demand special benefits. So that's what's underlying this loss of data when it comes down to it. And they've got 6 different ways in which they can attack the collection of data. One of the things that they didn't talk about, which is key to what we do, is look at a physician workforce that's being developed to try to address the lack of access to care. So Dr. Benjamin mentioned one element of it that you've learned from your colleagues, but the other part is that the access to care is governed by who practices in your community.
There it is.
And that's often based on your race. So by taking away the information from both patients and who's being treated, like Medicare, for instance, is no longer requiring enrollees to look at SOGI. They can easily do the same thing for race and ethnicity. What do you think we can do to try to head that off? Is legal challenges the only way to address it, or are there other ways?
Fantastic question, because that really brings to light racial concordance in medicine, in healthcare, dealing with the physician workforce. Thoughts,
Yeah, well, let me just say that there is a national effort to identify some of the most important things that government does now
Mhm.
that are going to stop being done and trying to get them done now by civil society. So as government pulls out of some things, people are trying to fill ways to fill that gap. That's clearly one way to do it. The other thing is um, to not, they seem to be able to write an executive order without any common sense. I think we can reverse it without any common sense too.
There it is.
Well, with common sense, not using old data and not the new data that they didn't catch.
Yes, yes. Any additional thoughts on that? Okay, Mary.
Yeah, I mean, I actually am also a lawyer, and I'm the immediate past president of the American Bar Association as well. And I actually have worked in White House counsel's office and drafted executive orders. So I am confident that new executive orders can be drafted very quickly. I know, and I don't know if all of you know, but like one of the executive orders that was rescinded on the first day of this administration was the equal opportunity executive order under President Johnson. Those kind of things need to be restored. And I think one thing that's so important is, just like we've been talking here today about public health and data, and I think Dr. Benjamin kind of alluded to this, there is a coordinated strategy to undermine trust in all of our institutions, whether it's data sets, whether it's law, whether it's judges. And I think all of us as citizens have a duty to stand up for that, to stand up for judges, to stand up for following the law. It is so important.
Yes, please let's stand up for those that are helping to enforce the protection of our rights. We are therapeutically agnostic. I'm going to take this last question, and then Carla, I'll turn it to you. We're therapeutically agnostic at the Data Equity Coalition, and so we really love hearing the diverse voices of providers, patients, industry, et cetera. Thank you.
Hi, my name is Jenna Lester. I'm a dermatologist at UCSF. And my question is about data ownership. Currently, our paradigm is whatever organization collects, aggregates the data is the one who owns and decides how it should be used. And I'm curious your perspective on that and whether you think that's the correct paradigm, especially considering some of the most valuable data that we have are data from communities that tend to not be able to access the technology that's used as a result of their data being collected, especially as we consider AI development and how important data is for the development of AI tools. And I'm just curious your perspective of whether we should have a shift in how we think about who decides where data is being used, and who benefits from the actual use of that data beyond whatever tool is being developed in its analysis.
Thank you for that. That's an important question. Carla, can you take that?
And I think in terms of, to be reductionist, the data of the people should be for the people, right? And so anything that is publicly collected with taxpayer money should be democratized. It should be publicly available. There's that. Then there's the personal data that you give your doctor. There are doctors, or there are practices rather, that charge for your own data, to get a printout of your own data. And that's cost prohibitive for a lot of people. And that is your data.
Right.
And so there's that component. There's also the fact, she mentioned AI. Public forums are being scrubbed for research, not only for AI, but for healthcare purposes. We have a document, the foundations of ethically using natural language processing, because scientists are going into forums that are publicly available, scrubbing them, making assumptions, deductions from them, and then using them. I think that community has been a bit more democratic in sharing the data, like in GitHub, and they're sharing. And so I think that's a good example of how that, even in tech, and yes, it's laden with biases that we perpetuate, but at least they're doing that where the data is available and anyone can try to go replicate their studies. So
Democratization.
democratization.
That key phrase. The panel's going to give you one final thought on their call to action on what you can do to help to support intersectionality, identification. We want you to be visible in healthcare, starting with Denise.
So what I will say is SPD 15, while the 2024 changes to it were great in terms of getting at disaggregated data, I don't think it went far enough. So I think advocacy needs to continue to make sure the changes in 2024 actually get implemented, but we need to start thinking about what else does SPD 15 need to do. We didn't get SOGI data incorporated into the standardized framework. Agencies within the federal government don't necessarily have to collect the data, but when they do, they have to use the framework. So requiring agencies to collect the data, giving transparency to the data, ownership of the data to the individuals, I think is important. And I don't think we're done.
We're not done.
And we're not done.
We're just beginning. Dr. Benjamin, 30-second final thought.
Yeah, there are no such thing as alternative facts. They're facts. And this administration lives in la-la land, quite frankly. And what we need to do is force them to use the truth, facts, in their data-driven decision-making. And when they say something, validate whether or not it's true or not. If it's not true, call them on it. And if it's true, then we ought to utilize that data. But we need to force them to do things factually based on data-driven
Data-driven decision-making. Love that. Mary.
I think we all need to be advocates in our communities and build coalitions and keep this issue at the forefront and not let us slide backward in the next couple years.
Amen. Carla.
Who are you when you are in a position of power? Do you divide or do you unite? And do you collaborate? And that's a little bit of self-reflection.
I love that. The Data Equity Coalition, wait a minute. The Data Equity Coalition website is dataequitycoalition.com. We have downloaded the SPD 15. All the information is there. They erased it. We housed it. We housed it. We downloaded it last administration. So it's there. So you can go and find out all the things. So we did protect and preserve. So we're asking for your continued support there. Turn to the person to your right and tell them that you see them. Tell them that you see them. I see you. I see you. Tell them that you see them. Right. This is about visibility, friends. This is about visibility. And if you are able, if you could just stand up for just 20 seconds. We are done. I just want you to stand up. I want you to stand up for data. I want you to stand up for data advocacy, data equity, for visibility, for democratization of data, for making sure that medicine is an art and a science, and to put your hands together for this incredible panel. They really did a fabulous job. Thank you, Carla, Dr. Alvarado, Mary, Dr. Georges Benjamin, and Denise Schofield. Thank you, audience, so much.
And I'm going to give a shout out to our great moderator,
Yes.
Courtney.
Thank you, Courtney. Thank you. Yeah.
Yes, sir.
Yeah.
Okay. Yep. Okay.
Good afternoon, ladies and gentlemen. Good afternoon. Hello, hi, welcome. Thank you so much for joining us at the NMQF 2025 Leadership Summit. My name is Nicole Varner. I am the Executive Director of the Congressional Black Caucus PAC. I know you ask, why am I here? And the reason I'm here is because Brandon Garrett told me to be here. So I do it. Also, formerly, I worked with the NMQF when I was Executive Director of the Congressional Black Caucus Health Brain Trust under the direction of Robin Kelly. Wonderful, wonderful woman. We are here today for this wonderful summit, and Dr. Puckrin shortly is going to come up and give a few remarks. But before he does that, I wanted to give you a little bit of background on the reason for this luncheon today, which is the Booker T. Washington Award. The Booker T. Washington Award recognizes an individual or organization that has made an outstanding contribution to the promotion of wellness in emerging populations. Booker T. Washington started the National Negro Health Week in 1915 to promote wellness in Black Americans. From 1921 to 1953, NNHW was a program supported by the Public Health Service. By partnering with Congress and the White House, 45 years later, NMQF started National Minority Health Month in 1998 as a successor of the National Negro Health Week. You may ask also why I am here presenting Dr. Puckrin to present this award. I'm from Alabama, and I think I'm the only person Brandon knows from Alabama. And we know Booker T. Washington founded Tuskegee University. Without further ado, I will introduce Dr. Gary Puckrin, whose bio you have heard numerous times this week, or these last 2 days, so I will not give it to you, and I will turn it over to him.
Good afternoon. Now, I first want to thank our sponsors, for which none of this could happen without them. So our platinum sponsors are Amazon, Amgen, Blue Cross Blue Shield, Centene, Genentech, Gilead, Merck, Novartis, Novo Nordisk, Pharma, Sanofi, Vertec, and the Rare Disease Diversity Coalition. So please, a round of a hand for our sponsors, and thank you. Thank you. Our gold sponsor is Johnson & Johnson, and our silver sponsors are the American Kidney Fund, the American Medical Association, Biogen, Eli Lilly, and PWR, and a great thank you to them as well. So what I wanted to do is introduce you to some of the staff at NMQF. And as you know, NMQF is organized around 6 centers. It's actually 7 if I include the Office of the President. And so I'm going to start off with the Office of the President, and then I'm going to ask each of the centers to introduce their staff. The way to think about NMQF is actually 6 nonprofit organizations that emerged as one, and each one of the center leads is actually like an executive director that manages their staff and budget, and they do just absolutely fabulous work. So I'm going to ask Venkata Dinesh, who is, he works at our health information systems, and Venkata has been working on the AI, and so if you've been out to our booth at all, please, Venkata, you will see a demonstration of our AI work. I can't tell you how I'm excited about that. We've been sitting on 5 billion patient records, and now we're introducing AI to help us interrogate that data, and he's been designing it and working on it, and just absolutely incredible work that he's been doing, and a big time thank you for that. Sharon Thomas Sharon has been working on our cancer stage shifting initiative. Here she comes. Cancer stage shifting initiative. She's been the project manager of that. I can't tell you what a big job and a great job that she's been doing. A lot of just handwork to make sure that whole system works clearly. So she's working with the public affairs, she's working with clinical trials, she's working with sponsors, she's working with the clinics and community, and really doing great work, and it's seamless, and it's really been an exciting program. That program is going to be transformative as it evolves, and I really want to thank Sharon for her great work. And Cecilia Masters, Cecilia manages a grant office. I'm going to have Cecilia come forward and introduce her grants team to you. Cecilia is fabulous, and y'all leave her alone because she's mine. Right? I'm just being blunt about it. I don't want y'all to get any mistakes in your head, right? So Cecilia, please, thank you.
Hello, everyone. So I'm going to introduce our grants office staff. Katie Chavez is our grants manager. And we have Raven Parker, that's also a grants manager, and I don't know where she is. And that's it for us.
Yeah, come, we'll do a quick picture together. Come. Are we going to sit down, go down that way? Go down? Yeah. Okay. So I'm next going to introduce Gretchen Wortman, who runs our Center for Public Policy. Gretchen has been with us a few years. I ain't going to tell you. She told me that. All right, so I'm not going to tell you how long she's been with us, but she's mine too. So y'all leave her alone. She does fabulous work. A lot of one of the things that people don't know about the great work that Gretchen has done, I know they understand the work that we do on Capitol Hill and the papers that we publish and the way we work with policymakers and looking at various laws and putting public comments in, et cetera, et cetera. But I think one of the most enduring things, and not all of it's important, but this one, I just have to point out to you. So in healthcare, it is an international classification of diseases called ICD-10. And so when you go to the doctor and the doctor treats you, he says, well, I treated her for diabetes, and he uses the code or cancer or whatever. Gretchen and her team has been writing some of those codes, right? Literally writing ICD-10 codes. And you got to know, it deserves an applause. You should understand that there are not any small organizations like ours that is writing codes. And the reason why those codes are important, because that's how doctors get paid. If it ain't got a code, you ain't getting paid. And so one of the ICD-10 codes, I'm sorry, Gretchen, go so long, but it's an important story, is for triple negative breast cancer, a disease that impacts African-American women disproportionately, and there was no code. So besides everybody getting paid, it also means you couldn't collect the data on where triple negative breast cancer was occurring. And so by helping to get that code through CDC and government and et cetera, and health systems using it, that's the work that Gretchen has been doing, just fabulous work. So I'm going to ask her to and be fair, please.
Thank you. And like Dr. Pucker and I brought pictures and names so that I don't forget my staff, but I do want to thank all of you for supporting us in developing the codes that
Dr. Puckrin referenced, we work not only on triple negative breast cancer, but on neuropsychiatric symptoms of dementia and stages of severity of Alzheimer's disease. Not alone, but with physicians who volunteered their time to work with us to enable us to understand what was important to factor into the coding, and with technical consultants who do indeed understand that the structure of the ICD-10 coding, which was revealing for us, I think revealing for Dr. Parkman, but as we're having conversations about health literacy, creating literacy regarding how the mechanics of the system works is absolutely essential at every stage, whether it's federal, state, or local. So thank you for all of your support and patience with us as we continue to move forward in aligning the incentives to engage with the needs of all of the populations whose biologies need to be represented and respected. I have a Center for Public Policy. I have a staff of 3. I don't even feel comfortable saying I have a staff. We are a team who work together, and I think work together very efficiently. And I've been fortunate to have 3 spectacular individuals working with me over the past 2 years, and I will introduce them alphabetically. Brenna Boyd, who's an analyst in program development. Brenna. Keiko Purnell, who's a law school graduate and works with us as an analyst in policy and regulation. And Dr. Britt Weinstock, who's a longtime colleague and joined us this year as Senior Director of Federal and State Policy. And many of you know Britt from the work that she did on the Hill with Congresswoman Christensen and Senator Bernie Sanders, and we are so pleased to have her with us now. So thank you.
To your left, come on. You don't let it slide, don't you? Thank you. And just by the way, public policy is a branch of medicine, because if you ain't advocating, you ain't getting. And so that's the team that's out there advocating for community. So thank you for that. Next is Akia Blue. She runs our Center for Sustainable Healthcare Quality and Equity. This is our church network and our faith-based network, and I'm going to ask her to introduce her team.
Thank you, Dr. Puckrin. Good afternoon, everyone. My amazing team that I'm going to introduce, I'm going to start off by introducing, she's not here with us today, she was here yesterday, but Dr. Laura Lee Hall is the founder and president emeritus of the center, so she's still very much involved in our work. Next, we have Chini Ukachukwu, because I practiced and I told myself I was going to mess it up. Ukachukwu, sorry. She is our senior director. And she leads our Faith Health Alliance work and our immunization work. And I'm so sorry, Chinny. I practiced so hard, y'all, on her name. Leslie Zuniga, who is our program manager, and she runs our Health Champions. And Shantia Horsford, who is our program coordinator, and she is working with our community pharmacist ambassadors.
Next, I'm going to introduce Akia Blue, who runs our Center for Communications and Public Policy. I'm sorry. That's your fault, Akia. Ezra Covington, I'm sorry, Ezra, who runs our Center for Communications and Public Policy. They're doing 8 billion media impressions a year and trying to get trusted health information out to our communities. Inside, they're doing mini clinics in community and health fairs. So, Ezra, please come and introduce your team.
Right. All right, well, I have to correct you. 6.5 billion media impressions a year. The B. So really proud to introduce my team. The Center for Communications and Public Affairs, we do patient education, direct-to-patient education, patient navigation, patient advocacy. So we're the patient-facing center. And so that processes everything from, cultural competency training, all that, education, as well as advocacy, going into communities, in district meetings, fly-ins. So come and stop by, talk to us. So I'm really proud to introduce our Director of Health Communications, Taylor Lopez, and she runs our Lift Every Voice Patient Networks. Victor Meja Lacayo, our Director of Marketing, and runs our For Your Health News platform. The amazing Marilyn Prempa, the Director of Events and Partnerships, who runs our NMQF Connect program. Okay, where's it? Okay, Dane White, our Internal Communications Manager. He is the gateway to NMQF. Yes. Jasmine Leonti, our Senior Events Associate. Ashley Hill, come on up, Ashley, Content Marketing Manager. I'm gonna make sure I didn't forget anybody. I'm gonna shout out to our intern, Subash. Come on up, digital marketing intern. Thank you, guys.
Get in the middle of this. We have a Center for Clinical and Social Research. We actually do clinical trials. And I'm going to ask Christina Edwards to come up. She's a Director of Clinical Research to introduce our Clinical and Social Research team.
Hello, everyone. Our Senior Vice President couldn't be here, but we want to recognize her, Janine Calkins. And myself, Christina Edwards, Director of Clinical Trials. Liu Zhu, Dr. Liu Zhu, our Senior Vice President, Principal Statistician. Dr. Michaela Kudre, our epidemiologist. Dr. Derek Forney, our research epidemiologist. And Dr. Jennifer Matas, our lead research epidemiologist. Thank you.
I don't usually say this, but I hope you guys got all them PhDs that just walked across the stage. And then finally, Kayla Amaru works with our professional services. Kayla, come up and introduce your center.
I got to pay the DJ. Last year I got Michael Jackson or something. Good afternoon. My name is Kelly Amaru. As Dr. Puckman said, I lead our Center for Professional Strategic Alliances. What that means is we serve as a hub for professional groups. We are probably the newest center at NMQF. We've established the center based on the need that we were seeing, and we have a number of programs, one of which is focused on kidney disease. It's an alliance for nephrologists for equitable kidney care. We're also developing a program for the 40 under 40 alumni. You know, this is the 10th year, and we've got 400 awardees of that program. So we're creating an alliance around that. We've got 4 other programs I'm not going to mention due to time, but I do want to recognize my large team of 1. So Michael DeSalvo Solarte. It's 2 of us, and most people think it's a team of 10. We do everything from ideation to implementation, the strategy and execution on the ground. So I do appreciate what Michael does, and thank you for all your support.
So finally, I want to recognize my partner in all of this, Brandon Garrett. So the 40 under 40 is Brandon Garrett. This summit is Brandon Garrett. Yeah, he told me raise the money, Brandon Garrett. And it's been an exciting and really productive partnership. We started working with Congresswoman Robin Kelly when he was Chief of Staff for Congresswoman Kelly, and it's really been a great alliance. And I thank you so much.
We're gonna take a group picture.
Yeah, okay. Okay. 1 second, we're gonna do a little team picture. I'll be right back. All right, So now you all know why I don't try to list all of these center leads and remember all those staff people, because I'm forever going to forget one person. And Margot Payne happens to be the person who gets designated as having not been called out today. But Margot, you come on up here, girl. Margot is the longest employee I don't even know how long we go back, girl. We've done a lot of different things over the years, and she's been absolutely fabulous. Oh yeah. So in the virtual world, most of the staff here, they don't work in our office. If you went and asked them, they're all from Florida, Texas. And Margot's the only one that comes in the office. It's she and I in the office every day. It's got, what was it, 2003, two, Lord? Yeah, the pandemic. Two? Yeah, anyway, it's been a moment. Yeah, yeah, you want to say? Too camera shy, don't worry about it. All right, give me 1 second.
Good afternoon, everyone. Um, First, I want to say thank you to our amazing team at SHC. I want to thank Laurelie especially for her confidence in me, for IKEA Blue, for this opportunity, and for every one of us there. But on behalf of the SHC team, it is my honor to introduce someone who you listened to yesterday, whose work has truly made a difference in the health and well-being of our city. Since 2022, Dr. Daphne Ferdinand has led a steady, focused effort to increase flu vaccinations across her parish and throughout New Orleans, especially among African American communities. Her approach has been rooted in trust, consistency, and a deep commitment to equity. Yep, I said it, equity. Under her leadership, the Healthy Heart Community Project has not only improved access to flu vaccines, they've built lasting relationships and helped shift community perceptions around public health. And this year, even when unexpected state policy changes threatened to derail their efforts, she and her team didn't back down. Instead, they adapted, they pushed forward, and once again, they raised vaccination rates in their city. That kind of leadership is rare, especially today. It is resilient, it's intentional, and it's deeply needed. Please join me with a round of applause in recognizing and celebrating a truly well-respected and well-deserving award winner, Dr. Daphne Ferdinand. Just her by herself. Just one, yeah.
Thank you so much, NMQF. Thank you, Chinny, for that introduction. Also, I want to thank Dr. Laura Lee Hall. I don't know what I would do without her. The Center for Sustainable Healthcare Quality and Equity has been the best for us with NMQF. We don't know what we would have done without her. I'm so sorry she's not here today. Laura said, Daphne, I got some more money for you. Okay, we're gonna do this again. And I'm so grateful for her, and also Sanofi for supporting her by supporting us to do this work. But not only that, our community who has stood fast and committed to ensure the public health of our city in New Orleans. But I also don't want to forget my number one team member, who is my partner in this community health work, who's been working with me on this journey, my husband, Dr. Keith C. Ferdinand. I couldn't do all of this work without him and his support. And thank you all so very much.
Good afternoon again. It's Kelly Lai with the Center for Professional Strategic Alliances. Each year, our team awards the Outstanding Leadership Award, and this year we're actually presenting that award to a team that's helped us organize kidney work that I mentioned about. So it's an alliance for nephrologists for equitable kidney care, where we think about reducing kidney disparities every part of the care continuum, from prevention to screening to diagnosis, and then treatment, dialysis, and even transplant as well. So with that, we relied heavily on our co-chairs. We've been fortunate to have 3 co-chairs, 2 nephrologists, as well as 1 that helps manage and operate dialysis centers. So we're awarding that award to them for profoundly relying upon you and helping prioritize and support our mission. So if you would please join me, Dr. Janice Desir. We also have Dr. Ruby Harford. Dr. Jensen Hall from Duke is unable to join us. He was here yesterday, so we'll accept that award on his behalf as well. So thank you. Yes, do you want us on this side?
So one of the perks of this position is that on occasion, I get to recognize and meet a hero and someone who probably didn't know the hell I existed, but nonetheless informed my youth and and I followed his career and deeply appreciative of having him here, and that is Alonzo Mourning. He is best known for his legendary basketball career in the 1990s and early 2000s. Among his many achievements are National Collegiate Athletic Association records at Georgetown, 7 NBA All-Star recognitions, an NBA championship, and a gold medal and induction into the Hall of Fame. At the height of his career, Mr. Mourning's physicians noticed signs of kidney disease during a routine physical and conducted follow-up tests to confirm his diagnosis, a rare kidney disease known as APOL1-mediated kidney disease. In 2003, he received a kidney transplant and resumed playing basketball. That says a lot about American science and technology. Helping the Miami Heat to an NBA championship in 2000. So you got some Miami Heat folks in here. In 2006, before retiring in 2008. Years later, in 2010, he participated in the research study that eventually led scientists to discover the link between the APOL1 genetic variants and kidney disease, which is overexpressed in African Americans, by the way. This is when he learned that his disease was genetically driven. Mr. Mourning is now an active advocate for kidney health and encourages others to be proactive as well. He has partnered with Vertex Pharmaceutical as a paid spokesman to raise awareness of AMKD through Vertex's campaign, Power Forward Together. It is my great privilege and honor to recognize and ask Alonzo Mourning to join. Oh, yeah. This is my privilege.
Wow. I get usher. Wow. Yeah. Good afternoon, everybody. This is a glorious day and a wonderful honor. It's a blessing to be here with you all today to celebrate progress. That's what we're doing. We're celebrating progress. Dr. Puckrin, thank you for that wonderful introduction. And again, I want to thank you all for being here. I want to first and foremost acknowledge my Lord and Savior Jesus Christ, for blessing me and just giving me another opportunity to be a voice, for the voiceless. I want to thank the National Minority Quality Forum for the incredible work that you all are doing. Absolutely. I applaud you all. I applaud all the other honorees. Please, y'all give them another round of applause. I applaud all of the folks that were recognized, that are leaders in the medical field, and the work that you all are doing. You all are moving the needle. You're making a difference, and we're tackling these negative statistics in our community, so I applaud each and every one of you all. I want to thank, the NMQF for their long outstanding work and continued commitment to uplifting underserved communities. Receiving the Booker T. Washington Award, we celebrate the contributions of Booker T. Washington every day. I have a Booker T. Washington High School right next to one of the feeder schools of the youth center that I run in an inner city called Overtown. And we understand, you know, his accomplishments and how they impacted our lives tremendously. And we understand that he was a prominent educator. And that's what we're here to do. We're here to educate our community. So we're carrying the torch. And it's a blessing to receive an honor in his name. So I'm very grateful for this honor. So thank you all. The promotion of awareness and health wellness is extremely important in our underserved communities. Health is wealth. It truly is. Without it, we have nothing. I don't care how big your house is, how much money you have in your pocket, how nice your clothes are. Don't none of that mean nothing if you're not. Trust me. And I'm a living, walking testament of that. You know, as a cancer survivor, last year, being diagnosed with stage 3 prostate cancer, having the surgery to remove it, catching it early and being proactive with my health, and then also being proactive with my health with kidney disease. 21 years now post transplant. So I'm very grateful. You know, and you know, uh, like the doctor mentioned, kidney disease affected my life, and FSGS, focal segmental glomerulosclerosis, was a disease that was told to me then. I did not know that I had this APOL1 gene, and everyone has 2 copies of this gene, and one from each parent. But having mutations in both copies is linked to an increased risk of rapidly progressing kidney disease. This disease can develop even at a young age and can advance faster than any other kidney disease. People of African ancestry from Western or Central Africa who may identify as Black, African American, Afro American, Hispanic, or Latino will inherit certain variants, also known as mutations, of the APOL1 gene, and it has increased a risk of developing the AMKD, which APOL1 mediated kidney disease, which is what happened to me. Again, this was 21 years ago, and we've made a tremendous amount of progress since then. And like it was mentioned through my partnership with Vertex Pharmaceuticals, we're educating as much as we can. Uh, Acknowledging again that, you know, a very disproportionately amount of people who are African American or of African American ancestry are the ones that are dealing with this, and many of them don't even know they have it. A lot of times we ignore some of the signs and symptoms until it's too late, and then a lot of people of color aren't even aware of what a nephrologist is, or even told to go to a nephrologist until it's way too late. So, so today we celebrate APOL1 Awareness Day. This is the second annual APOL1 Awareness Day, and I'm grateful to be a part of it. It emphasizes the need for members to be actively leading the charge and discussions in their respective communities around this topic, kidney disease. It's ravaging our community. It truly is. Not including diabetes and hypertension, which we lead in a lot of those particular statistics, but AMKD is one that is silent, and that if we are proactive and we encourage our community to at least go to the doctor at least once a year. I know it's a lot of difficult, especially for Black men. It's very difficult, you know, because of fear, finances. There's so many different obstacles that stand in the way, you know, but our families rely on us. And it's important for us, you know, to take care of our health. We can't wait for nobody else to do it for us. We have to be the participants in our own health, you know, which is why through Vertex Pharmaceuticals, we put together a website called powerforwardtogether.com. And I have testimonies, and we also have information to help educate our communities and help them navigate uh, through this, through the obstacles of kidney disease, and also to know what questions to ask your doctor when you're in the doctor's office. I know how difficult it is to even get to the doctor, but when you get there, there's such a level of fear and distrust that you don't even know what questions to ask the doctors, you know. So having a website to go to, powerfortogether.com, it tells you what questions to ask your doctor, how to have dialogue with your doctors and what have you, you know, and so we can tackle these statistics. Again, this is a wonderful occasion. Thank you so much for this acknowledgement. I'm glad y'all got a tall enough podium for me. And this is truly a blessing. Thank you all. God bless you all. Yeah, okay. Do it. Do it here? Do it here. Got it.
Of course. Thank you so much. Hello, I've returned to close you out for this afternoon. Don't we love a brief program? This was nice, short. This is exactly how I like it. Also, I have an announcement. I stand corrected. Brandon Garrett has deep roots in the state of Alabama, and I am not the only person he knows from there. Thank you for having me today to participate in this ceremony. And before I close, can we have another round of applause for our awardees and NMQF staff? The work they are doing and the support from all of you out there is extremely important to our communities across the country. So we thank you all for being here with us. And I think the remarks we just heard from Mr. Morning were a perfect lead into your next panel, improving kidney care for the community. Thank you again for your time and attention, and enjoy the remainder of the amazing programming for you today.
That's infected. Maybe getting a tattoo at a 3-day music festival was a bad idea. Lucky for you, an Amazon One medical virtual visit can happen anywhere. Even here. An Amazon pharmacy will deliver antibiotics right to you. So you can breathe easy. Well, sort of.
Sure. It wants to stand.
Oh, okay.
Thank you.
Good afternoon. If we can all take our seats, we'll get started with the last panel of the summit. All right, I think we're ready. Good afternoon, everyone. I know that post-glycemic fatigue is kicking in, so we've saved the best for last. My name is Kelly Amaru. I'm Vice President for our Center for Professional Strategic Alliances under NMQF. And I'm happy to be here on discussing such an important topic. So this last session is going to be focused on kidney. How many of you all remember the theme for our summit? There you go, data to action. I owe you a drink at the reception. From data to action. So we actually really wanted to focus on what does that look like when it comes to improving kidney for the community, for the underserved community. So we wanted to focus on everything, every aspect of the care continuum when we discuss kidney care, from screening, prevention even, screening, diagnosis, treatment, and all the way through survivalship. So we'll get into that. Let me introduce my panelists. We've got Dr. Janice Desir, who's actually a community nephrologist who also leads as one of our co-chairs for our Nephrologists for Equitable Kidney Care. She does tremendous work, also practices at Kidney Medical Associates, and she's in private practice been trained in both internal medicine as well as pediatrics. We also have LaVarn Burton, who is the Chief Executive Officer for American Kidney Fund, which is a national nonprofit organization whose mission is to fight kidney disease and help improve people's lives. We have Maurice Madden. He's the Director of Community Engagement at GlomCon, which is an organization composed of healthcare professionals. They have a mission to provide medical education and on best available evidence. So as we get into the community discussion and how we get disseminate information, that'll be huge. And then last but not least, we have Sean Greminger, who is the president and CEO of the National Alliance for Healthcare Purchaser Coalition. And Sean brings the National Alliance working with coalitions, employers, and other healthcare purchasing, which is also important in this space. So thank you all for being here. I want to preface this discussion by saying, you know, every year, dating back to when the summit was first held, we talk a lot about the statistics, where the disparities exist, where the gap is. And I've gotten a chance to look at quite a bit of the data NMQF has. And all the inequities that exist in healthcare, kidney tends to be one of the most significant ones. And it doesn't get the limelight that it deserves in terms of the work that needs to be done. And I'll just throw out two statistics. 9 out of 10, this is according to NIH, 9 out of 10 kidney patients don't even know or they're not aware that they have it. And if you're Black or African American, it's 3 to 4 times likely to end up on kidney failure. So those are just two important ones, but I don't want to be here 5 years from now still talking about how do we cut this disparity down when it comes to kidney disease or any other condition for that matter. So I want to focus on the disparities and, more importantly, what we can do to cut down on those disparities, working at the community level. So we'll get in touch. We'll talk about social drivers of health and the important role that they play, the genetic factor, policy, and then how we get this information going on a community level. So I'll start with you, Dr. Desir. First question is, when we're dealing with social drivers of health and all the different components from what we eat to the air we breathe and the water we drink, the environmental exposure, and the contribution that has on kidney health, as a nephrologist, how does that play a role, a factor, with 9 out of 10 people not knowing that they have it, and then with the general public even doing some things that may be damaging their kidneys and not being aware of it, which is mostly the case in a lot of our communities.
Yeah. Well, first, I just want to say thank you to NMQF for the opportunity to be on this distinguished panel to talk about something that's obviously very important to me. And I think with your question, we often think about medical care is lab tests, and it's going for imaging, and it's taking some medicines that we get prescribed, because we think that organ dysfunction is based on specific symptoms related to that organ. What we are starting to better appreciate, I think, in a more global community, and I know I certainly am as a practitioner, is that a lot of health outcomes is based on your social environment, where you eat, where you play, the things that you do that make you happy or sad, right? Those impact the way dis-ease or unwellness is shown in your body. And so I think when you think about social drivers of health, there is a movement to really understand that that's going to help have an effect against, essentially, on what's going on essentially with any chronic condition you have, but in particular kidney disease. You know, the majority of people who have kidney disease, it is related to things that actually can be impacted by the things that they eat, the environment that they're in when you think about diabetes and hypertension. And so I think for us in this space and talking about that, it's more of an awareness that we need to understand that social drivers have huge impact. But I think when you think about social drivers, there's 2 different umbrellas to think under this. Number one, social drivers of health is really talking about root causes of what can cause adverse outcomes. Economics, housing, your kind of access to quality health. But then those big drivers essentially have individual consequences, and that's defined as health-related social needs. And I don't know if that's a term that we're using as often as we should, but we should be distinguishing the two and understanding that the individual consequence of what happens to your body when you have unwellness, especially in kidney disease, is what we're talking about today, is a health-related social need. And so with that said, how do we kind of distinguish the two, and how do we realize the ways that we look at these social factors and integrate this into our common practice, that when you're seeing your doctor, that you as a patient are being an advocate and telling them all of these areas that are affecting your life, because whether or not you appreciate it, it absolutely has relevance in kidney disease management.
Thank you so much, especially for creating that differentiation between social drivers of health, and we're hearing terms like health-related social needs, and transitioning into genetics and the role of genetics. This was a great transition from having Alonzo here earlier. He talked about having the genetics, the genetic predisposition. So how much of a factor does genetics play a role, and what can be done in terms of screening programs to make people aware that they even are at risk or have that risk factor?
10% of conditions that cause kidney disease are related to genetics. And I know we're going to talk more about specific genetic conditions, but in a broad-based sense, there's 2 ways this can happen. It can either be that you have a genetic condition that increases your risk to get kidney disease from something completely different. Or it could be the genetic condition causes a specific type of kidney disease. And certain populations or groups are impacted by one form or the other. And I think with that said, communities, and I can tell you too, the communities where I serve, the access to get this genetic testing is improving, but it's not easy, particularly if you're in under-resourced communities. Because insurance has to approve it, you have to give a justification as to, what is the indication for the testing, and the reality is we're not talking about it as families. All you know is that you know, somebody in your family has kidney disease, and if they fit one of the common bills of diabetes and hypertension, you haven't justified a reason for that genetic screening. But again, there's a movement to get more awareness and insight into this, and I know, again, we're going to expand on this some more. And so with that said, it is something that should be just as much a part of our medical visit as all the other things that we ask.
Thank you so much. And switching gears and coming to you, Laverne. Today is actually AMKD Awareness Day. It's APOL1 mediated kidney disease awareness day. And so with that in mind, how can we talk about a genetic condition that disproportionately impacts communities of African descent? Can you weigh in on the steps your organization is taking and what's being done to, again, to screen and create awareness so folks are even aware that they have that risk factor?
Thank you so much, and thanks to all of you for being here. I want to pivot off of some comments that Alonzo made. How many people in this room have ever heard of AMKD or APOL1 mediated kidney disease? Great, great, great. This disease was fairly recently discovered over the last decade at NIH, so that's also a, let's applaud the federal research bureaucracy and the importance of their work. We started last year with a congressional proclamation that really announced AMKD Day. And there was the reason we wanted to do that goes back to the statistics that you mentioned, which is that, of the people who have kidney disease in this country, only about 90% of them know it. And that's the number that we estimate to have it. Many more who probably have it and we don't know. And so it is definitely an uphill battle in terms of increasing the awareness about kidney disease, period. And then you add on to it all of the social driver factors and now this genetic factor that specifically impacts people who are of Western and Central African ancestry. And those, if you are much more likely to have AMKD, if that's your ancestry. It really represents a variation, a variant in our APOL1 genes. Everybody has two, one from each parent. If you have two mutations or variants, it puts you at very high risk for the disease. About 13% of Black Americans in this country have two mutations, and about 1 in 5 of those will get AMKD or APOL1 mediated kidney disease. It very often strikes people. I've heard Alonzo tell his story in more detail. Strikes people when they are very young. He became ill right after he participated in the Olympics. It also moves much faster to kidney failure than other forms of kidney disease. So there's an urgency about making people aware and giving us all some tools that we can use to deal with this disease. That's why we started at the American Kidney Fund, we started AMKD Day, and we're appreciative of the opportunity to have this platform to talk about it. This is a second observance. And so some of the things that we've done. Last year, we did a congressional briefing and reception with Alonzo. We've also worked with him. In fact, just last week, he and I did a national radio tour all around the country telling people about the disease. We're here today. This past weekend, we had a town hall meeting in PG County with Congressman Glenn Ivey. We've got an article that's running in Essence magazine with one of our patient ambassadors, young woman talking about her experience. Everything that we can do to get out the word about this disease, we want to do that. And we want to also empower everybody who's within hearing of my voice to do something as well. We have a toolkit, an AMKD toolkit on our website. Go to kidneyfund.org/AMKD. And you'll not only see that toolkit, but lots of information about this disease that you can use with your social media outlets, with talking with friends and family to talk about this disease. it is really just of the utmost urgency that people know about it because it moves so rapidly. We want to make sure that not only do we know if we have kidney disease, but that we know the cause of that disease because the treatment can be different. And so those are all the things that we at AKF have a great sense of urgency about achieving, and we invite you, we urge you to join us in this battle to make this disease better known.
Thank you so much, LaVarn. Maurice, let me bring you into this conversation. We know the historical aspect of why there is a mistrust or a distrust when it comes to certain communities in the medical community. But in terms of the importance of involving the community in some of these solutions to create awareness, whether it's genetic risk factor or to go get screened, how important is it to involve the community, and what are some of the things that you all are doing to recreate and build that trust with the community?
Well, thank you for that question. For the past 3 years, I've been doing a lot of work in the community, and there are some things that I've learned when it comes to engaging individuals in the community. And there, you're right, there is a lot of mistrust. Going back to some of the startling statistics that you gave when you began the panel discussion, what I'm seeing is that it's important that we can continue to make people aware, get people educated, screen people, because that's going to be the only way we're going to know how we can tackle this issue. Going back to what Ms. Burton said, awareness is very important. Some of the organizations that I work with in the community on behalf of GlomCon, I spend a lot of time with houses of faith. And the reason why I do that, going back to your question about trust, I have found that many people that attend houses of faith, they put a lot of confidence in their faith leader. And I have seen faith leaders get in the pulpit and say, hey, you need to be screened for kidney disease. And the minute the pastor says it, they line up and they go do it. And just thinking about, what Alonzo was saying about go to the doctor, yes, those of us that can go to the doctor, go to the doctor. But there are so many people in communities that don't have access to health care. They don't go see their doctor on a regular basis. And because of that, what we've decided at GlomCon to do is let's take the doctor to the streets. Let's take the doctor to organizations where the doctor can be there, assess the situation, and let them know where they stand. So trust is very important. Another key group of people that we're seeing, or that I'm seeing as I get into these communities, is barbers and beauticians. People love to go in and guys get a haircut, ladies get their hair done, and they're sitting there and they're talking to the person that's doing their hair. And to a certain degree, it's like they look at them as sort of like being a psychiatrist in a sense, because they bring all of their problems to them and they talk to them. And it's like if that barber or beautician is saying, look, get screened for kidney disease, get screened for APOL1 because it's serious, then they have that influence on the individuals in the community to make sure that they're doing what they need to do.
Thank you, Maurice. Returning to you, Sean. There's a lot going on in healthcare nowadays, and focusing on the policy front, there are a number of efforts to advance healthcare. There's a lot of discussion around healthcare value. How can we make sure these policies have the community in mind and prioritize outcomes, improvement, and care across the continuum that we're discussing? Where would you start with that? Because the community often doesn't have that agency to advocate for improved outcome and improved care.
I appreciate the question. So just in very brief, so I represent the National Alliance of Healthcare Purchaser Coalitions. We're a membership organization based here in DC. Our members are about 45 regional employer purchaser coalitions around the country, and they themselves represent employers and labor, so private employers, cities, counties, states that employ their staff, labor unions, et cetera. And as you probably know, although I think a lot of folks don't spend much time thinking about it, a majority of people in the country actually receive their health care through their employer, their spouse or partner's employer. So we're a significant part of kind of the commercial market, where I'm guessing most of the people in this room get their health insurance. And I will just also stipulate, I am not a clinician, and most of what I heard said earlier were things that I did not understand. I could not identify a kidney on a lineup of internal organs. So that's sort of my level of knowledge as it relates to the clinical aspects of kidney disease. But I'm really pleased that we were able to do in partnership with the American Kidney Fund, the National Alliance has put out a white paper issue brief around kind of the impact of kidney disease on American workers and their employers. And we're going to be following up with an action brief that's really aimed at the employer market, so my members, to help them understand. And you will not be surprised to know there's a dramatic impact. So 11% of working people in the United States have kidney disease. 90% of them don't know it. That's 7.5 million people just in the workforce. The number of people who have late stage kidney disease, stage 3, 4, 5, is less than 1%, but makes up maybe 8% of our overall costs. And at the National Alliance, we spend a lot of time talking about the cost of healthcare, because if you haven't noticed, it's really expensive, and we're trying to do something about it. So going back to sort of the value question, I'll be honest, I am a value-based care skeptic. Not because I think that value-based care is a bad idea. I just think we haven't actually seen it done yet, and we've been talking about it for 20 years, and I'm kind of tired of talking about something that seems to be a unicorn. So at the National Alliance, and I think in the employer community, I'm encouraging people to think about value in a much more sort of simpler framework, which is, for us, value equals quality divided by cost. And quality has a couple of aspects to it. It's what are the actual outcomes? What's the patient experience? Like, was the patient happy with the care that they got? Did they feel like it was meeting their needs? Was it culturally competent? Did I say access? Access, so like, can you actually get to see the people you need to get to see? And then health equity, which we think is absolutely critical in the employer market. So when I look at sort of the kidney disease space, I'm not sure we need a really complex, overly contrived value-based care metric and framework. I think what we need is better access to care, better patient experience, a real focus on equity, because we know in particular in kidney disease there's a huge disparity, and we need it delivered at an affordable price. And this is where, and we'll talk more about this, how important it is for employers and other payers to be investing in upstream kidney care, where we can make a much bigger difference and avoid some of the incredibly high costs associated with end-stage renal disease and other kind of late-stage kidney disease.
Thank you so much, Sean. So for the general public, especially for a lot of patients that are unaware of policy and how that directly impacts the care that they receive, focusing on that and coming to you, Dr. Desir, we're seeing constant changes. Most recently, there was the ESRD payment bundle, the end-stage renal disease payment bundle that went in effect as of January 1st. How are some of these policies impacting? I know we've heard a lot from our own members with NEC in terms of the logistical nightmare that it's creating, and then even down to access issues with patients finding certain prescriptions. How is that impacting your practice, and what are some of the things that you're hearing from your patients specifically?
And I think before answering the question, I guess I just want to level set our understanding of a few things, because we're throwing around some terminology, but I want to make no assumption. So when we talk about CKD, what it's calling that is chronic kidney disease. And chronic kidney disease is a spectrum. It's essentially the slow decline of your baseline kidney function. And when you get to the end stage, the final stage, that's when we call it end-stage renal disease. There are those who reach the final stage and choose not to pursue dialysis. So we call that chronic kidney disease stage 5. And that can often be our more elderly patients who have just chosen they want a certain quality of life. But the person who reaches CKD 5 and decides they want to pursue dialysis And transplant as well isn't, because it's a treatment option essentially for those who reach end stage are called end stage renal disease. And the reason I say that is because in talking about reimbursement, their focus of where the government prioritized reimbursement is on end stage renal disease. To Sean's point, that's not really preventative, right? What you're doing is just treating more and more people to get to the final stage instead of trying to prioritize being more preventative. There are movements where we are trying to work on getting reimbursement for CKD education, but that depends on the type of insurance that you have. Medicare commercial insurance puts a lot of effort in that. Medicaid, it depends where you live in terms of if they have the dollars to do that. But it won't surprise you that there's likely a large number of Medicaid patients who need that education just as much as the Medicare and commercial patient. So with that said, when you're looking at ESRD and the payment bundle, the bundle for those who are on dialysis, there's a distinction between saying that I am saving money and I am getting value. Okay, so the bundle is looking to save money by taking all of the things, the metrics that the dialysis center and unit is being judged on, and giving it a consolidated cost. And the most recent thing that has happened is that part of what dialysis patients need is medications to help control their phosphorus levels because it can get very high as a consequence of inadequate clearance. In doing that, there is 20 million different flavors, essentially, and not all flavors resonate well with patients. And so what you're asking the dialysis center to do is essentially become a pharmacy, when really our job is supposed to be to provide the treatment of the dialysis. And so with that said, problems are happening. I was just talking earlier to our co-chairs, Dr. Hall and Dr. Harford, and Dr. Harford in particular was sharing how in her units, number one, well, they had tablets for one of their phosphate binders, and really the patients did better with swallowing capsules. So now they had to order a whole different type of medication, but there's a delay in receiving that. And separate from that, what if you have mail order instead of pharmacy, right? Which a lot of our patients have mail order. So I prescribe something you today, I need to wait 5 to 7 days for you to receive it from the mail. So what's happening in the interim? And my dialysis center was never designed to be a pharmacy. Where am I supposed to put the medications for the 100 some odd patients that come to my center? So the implementation of what was intended to be cost savings is not really of value. And ultimately, the execution sometimes of these plans is where I feel like there's a limitation in understanding. You can say whatever you want verbally, you can write whatever you want on paper, but until you're hearing the lived experience of the patient first and foremost, but those who actually care for the patient to execute your plan, it's not the most ideal plan. And I think that's the barrier that we're starting to see here in terms of how the implementation of the modified bundle, particularly with phosphate binders, is affecting dialysis centers across the country.
Thank you so much for shedding light on that. Dr. Puckton often says everything starts with policy and ends with policy. So LaVarn, coming to you, we're hearing and seeing a lot in terms of the policy changes, and how do we make sure the changes that are happening in terms of policy have health disparities when disparities is becoming weaponized? The word in itself is just a dirty word in some areas. How do we make sure it's changing in a way that it's impacting the disparities that is the reality for the communities that we serve?
Thanks so much for that question. Before I answer that question directly, I want to talk a little bit about the way the kidney care system works in this country, the way the payment system works, and connect it to what Sean said about going upstream. If you are in kidney failure, there is one good thing about it, at least one, which is that within 3 months of being diagnosed, regardless of your age, you automatically become eligible for Medicare. That's been true since the early 70s, and that's great because you need access to that health care. But what that has meant is that money, public money for healthcare treatment is on that back end. And so, as Dr. Desir said, it's almost as if you are waiting for somebody to be really, really sick, end-stage renal disease to the fatal point before you do anything. That's really kind of dumb.
Backwards.
Why would you not provide the care that people need up front so that they don't get to end-stage renal disease? Why would you not provide the care that they need up front when the care is less expensive, when it's less disruptive to people's lives, because when you get to that end stage, you're going to dialysis 3 times a week. It's kind of hard to keep a job when you've got to be on dialysis 3 times a week, 3 or 4 hours at a time. The preparation is difficult, the recovery is difficult. It changes your whole life. So as Sean said, we've got to make the case from a policy perspective. We need the funds that are available to take care of people if, unfortunately, they are in kidney failure. And we shouldn't change that. We should change a lot of the way that we go about paying for them, or not adequately paying for them. But we need to move some of those resources upstream, because another good thing about kidney disease is that depending upon the cause of your kidney disease, it can be preventable. Once you have chronic kidney disease, it is not reversible. Some folks may have acute kidney injury, and that's different. We're not talking about that. We're talking about chronic kidney disease, which is progressive. It's not reversible, but it can be slowed down. But it can be slowed down with attention, with proper medical treatment, with lifestyle changes, with all those things, so that hopefully you're dealing with the CKD, chronic kidney disease, but you don't get to that point. Here's another public policy argument that we're facing today, which is this. In this country, about 1 in 5 people get their health care paid for by Medicaid. If you look at people who are dealing with specifically kidney failure with ESKD, you're talking about 45% of the people who are in kidney failure getting their health care partially paid by Medicaid. 80% get their health care paid for by Medicare. So obviously there's some crossover. Most of that 45 are dually eligible for Medicare and Medicaid. So that when you start talking about reductions in public programs, Medicaid, Medicare, you're talking about pulling the rug from under people when they're really, this is their last option. They are in kidney failure. There are no other resources available to them. They can no longer work because of the disease and the intensity and longevity of the treatment. So it directly impacts this population, perhaps even more so than many other populations that are dealing with chronic disease. So we will be doing everything that we can. We're always doing everything that we can to support public programs, Medicare and Medicaid. We're always, as an organization, fighting to make improvements in the Medicare bundle and in just looking at the payment system and whether indeed that is the best payment system. But there are other things in terms of public policy that we also need to be very concerned about, particularly in this population. AMKD that I talked about a little bit ago, Alonzo talked about it. Alonzo has the gene variants, he has AMKD. That was a recent discovery through the work of NIH. That's the kind of work that we have being done by our biomedical research centers. We need to protect that, to fight for that. If you look at the FDA, we went a long, long time with very little or no innovation in the kidney space. In recent years, we have begun to see the new therapies being approved. Now that that is finally happening, now that there are finally treatments, and AMKD is one that we think is really very, very close to having a specific treatment. We want to protect that, we want to encourage that, we want to support that. And all of those policy efforts need to go toward continuing to support progress for new and innovative treatments and for research, and they also need to go for protecting access through public health programs like Medicare and Medicaid.
Thank you so much, LaVarn. Sean, I want to bring you into this conversation just to chime in on that front as well, especially when we're thinking about going upstream In your work, especially dealing with an entity like employers, employers are more recently investing in overall healthcare due to how much it's costing them. Um, what can be done to work with employers again to go upstream and create that awareness, the prevention, and do some screening, especially for communities that are at risk?
Yeah, so a couple of things, and I 100% agree with everything LaVarn said. Ultimately, I think the way that we pay for healthcare determines how we deliver healthcare.
Right.
And we talk a lot about, and this is a slight diversion, but we talk a lot about, it's only a slight diversion because actually it has to do with preventative care. We have a real challenge in the primary care workforce today. There's a lot of complicated solutions for that. My answer is a pretty simple one. We should pay primary care doctors more. We should pay nurse practitioners more. If we pay them more, there will be more of them. They'll be more likely to re-enter the workforce. The many have retired. We will have less of a problem. And we probably need to pay other people less. And we won't get into who needs to get paid less, but there are plenty of people in healthcare who need to get paid less because we have too many of them. And so as we look at how employers sort of are thinking about this, I mean, for one thing, I think an important piece that the National Alliance is trying to do, in collaboration with AKF, is just better employer education. Employers have ability sometimes to access their own claims data and look at it deeply. It's still very difficult for them to know who within our workforce has kidney disease because, again, screening is so poor, there's very little of it. However, there are certain markers, and again, I'm getting kind of close to the end of my skis here in terms of, I don't know how to find a kidney in a body. It's somewhere in here. Yeah, but there are certain markers of kind of care patterns that you can see that would indicate, hey, this is a person who might have kidney disease. So one of the things we're trying to educate employers is to actually start looking out for this and really targeting communications to people who are more likely to have kidney disease. There are certain subpopulations, certainly African Americans, who are more likely to have kidney disease, certain age groups, certain behavioral issues. So how do we help employers identify people earlier on and say, hey, we really want we want everybody to go get screened, but we really want you to go get screened. The other thing that we need to do is actually, I think, as LaVarn said, see a shift in the way that we pay for kidney care today. The fact that Medicare pays for dialysis for people with ESRD is fantastic. It's the only population that I can think of under 65. ALS. I should know that. My dad had ALS. So it's fantastic that happens, right? Dialysis is extremely expensive. The fact that Medicare is willing to pay for folks under age 65 to receive dialysis is fantastic. But there is a perverse incentive for employers, right? And I don't think they're thinking about this consciously. But subconsciously, if you have a person who hasn't been screened for kidney disease, therefore they're not kind of showing up in your claims, you're not paying for any of the drugs, they're sort of hidden. And then once it's really bad and they're really sick, there's a waiting period and then they get to go on Medicare and you don't have to pay for them at all, right? So there isn't a lot of financial incentives for employers to do the right thing. Now, that doesn't mean some employers aren't already doing the right thing, but part of it is how do we change that financial incentive? We've been working on draft legislation, talking to AKF, talking to Novartis about a sort of shared savings model that would enable Medicare to help employers cover the cost of upstream kidney care to include screening, and then all of the things that you can do that are relatively less expensive, certainly a lot better for the patient population. Again, not a kidney expert, but a person with stage 1 kidney disease can live, if properly treated, can live a pretty decent life at relatively low cost to the employer. And if we can keep them in stage 1 and maybe stage 2 for a longer period of time, everyone is better off. But I think helping employers sort of make that move financially is going to make a difference.
Thank you. LaVarn, did you want to chime in on that?
I wanted to tease out something that
Yeah.
Sean said. When we look at the Black population, all people get kidney disease, chronic kidney disease, or are likely to get chronic kidney disease. Blacks don't get chronic kidney disease disproportionately. Blacks get kidney failure disproportionately. Blacks are 4 times more likely than whites to get kidney failure. And we've got to look at what happens between stages 1, stages 3, 4, 5.
So that's largely a product of effectively a failure of the healthcare system to keep it.
It's a failure of the healthcare system. It's the higher rates and sometimes very very difficult to manage, high blood pressure and diabetes, but it's also things like genetic diseases, AMKD that we were talking about today. And you know, for me, and I've been in this field now for, hard for me to believe, 20 years. This question has always been top of mind. If you're not disproportionate at the starting gate, why are you so disproportionate at the end? And I think the genetic base gives us a lot to think about, together with what's going on with high blood pressure and with diabetes.
Absolutely. I think you bring up such an important piece of this, and I love the discussion that we're having. And one thing that I've been reading a lot about is epigenetics and the role that environment plays interacting with our own genes. And that can often exacerbate the predisposition that you have to certain genes. So it's certainly what happens under the skin based on what you eat, drink, where you live, the air you breathe. As a nephrologist, what are your thoughts on this, and how much of a factor is this playing into Blacks having 3 to 4 times more likely to end up on end-stage renal disease?
So I think it's huge. I mean, I think if you were wanted to think in terms of like real life examples, if we talk about somebody who's having issues in economics, which we'll call essentially like a social driver of health, and then you're looking at the health related social need, what is the individual consequence of that? Well, maybe you live someplace with food insecurity or nutrition insecurity, which is a distinction. Food insecurity meaning I don't have access to foods that are healthy and well. Nutrition, I don't have access to the right foods. Maybe in my area, there's like, 50 bodegas to every 1 or 2 supermarkets. And so because I don't have that, my doctor told me, well, low salt diet. Okay, well, I'm going to get the healthy microwave meal, not realizing there's 600 milligrams of salt in that. And you had that for lunch and for dinner. And you promised me when you came into the clinic, and I believed you, that you were eating something that was low salt. And you know what, I only have 15 minutes to get through this visit. And in this 15 minutes, I'm giving you the pearls and the wisdom. But what I don't have the time to is really unravel the depth of what your social environment is, to unravel the fact that, you tell me you have such and such profession, and it seems like it's a really solid paying job, but maybe you're not getting paid enough, and you're a caretaker of your elderly mother, and you have to decide between getting her medicines. We don't have that time in the 15 minutes. And so I think, to your point, when you think about the epigenetics part of it, that's stress. Stress is inflammation. Inflammation causes dis-ease, unwellness. We don't talk that way. And I think really in thinking of the space of where community advocacy is so important, during the presentation, someone made a comment about how we need to kind of unravel the mechanics of what goes on. And I think those involved in the space of community advocacy, this is where I could tell you, I need help. I need help for the patient, not because I don't want to, because I don't have the time. I wish I could, but the volume is so big and the epidemic is growing. And I wish they understood the ways that those mechanics influenced what I can do. So when you come in, you're telling me, listen, here's my stressor going on. And this is the reality of how hard it was to get access to that food. And then I'm taking the lab data and I'm taking the test and I'm giving you a real assessment where I'm like, I got it, okay? And maybe some of the things that I'm recommending may not seem conventional, but if that's what gives you emotional peace and wellness, if that's the way to be realistic about how we can get better foods in you, even if it's not ideal foods, that we can make a realistic plan, that's to me how you get better, right? Any step forward is a step of progress. And I think sometimes as clinicians, I will say we are very unrealistic about what we ask our patients to do when we don't give them the proper tools to do it.
Wow. So Sean, a lot of what we're talking about has to come alive in the community. So how do we translate that work based on your experience in the community? What can we do to build trust and establish that credibility so that awareness, the literacy, even for patients who may have that genetic predisposition or based on where they live, they might be at risk. So what can be done, and what would you recommend so that the community can actually have this and armed with the tools? I'm sorry, Sean, this is going to go to you, Maurice.
I was thinking that was from Maurice.
Well, I think what we would want to do is look at organizations that are committed to working in the community. I think that it's really important to identify individuals who are passionate around helping individuals that may be at risk for kidney disease. Once they are screened, we certainly need to have a mechanism in place to get them to care. Uh, if there's a way that we can possibly get them into a clinical trial, I think that we need to do that because that's very important. I know what I've been doing for the past 6 months is I've been going into different cities. I've been working with nephrologists. I've been working with registered nurses, student nurses, medical students, volunteers, you name it, just bringing a family of clinical experts together to go to different places. Whoever wants us to come in, we bring those individuals in, and we have, like I say, houses of faith or the links or Black Men's Wellness Day to do the marketing piece of it, where they're bringing these people to us at these specific places, and then we start the screening process. We go as far as having, intakes done where if a participant wants to come and be screened, they can complete an intake form, and then a registered nurse will check their blood pressure because we know blood pressure is very important when it comes to chronic kidney disease. And then we have another nurse to actually give them a urine cup so that they can go to a restroom nearby to give a urine specimen. And then a dipstick is done to measure the amount of protein that's in the urine. And then they're passed off to a nephrologist. We've been fortunate with companies like Vertex, who has been sponsoring genetic testing, to they've actually purchased genetic test kits from Natera as well as Arcana, so that those genetic tests are on site and it doesn't cost anyone any money to get screened, because we know that that's a really important thing that's going on. So when we break it all down and we have the nephrologist to actually examine and weigh the results of the proteinuria, the genetic test is given, a saliva swab is taken, kit is packaged, is sent back off to the lab. The lab in turn measures the results, sends the results back to the nephrologist. If there are 2 mutations of the APOL1 mediated, gene, then what the nephrologist does, he gets in contact with the person to let them know what their status is so that they can be guided into an area through a clinic if they don't have insurance. But if they have insurance, they can go to their primary care physician and get more information and then go through a process that way. So we have steps in order to make sure that we are getting individuals screened in the community. But what's even more important is, like I say, to have ministers and these pillars in the community to speak to individuals and talk to them about how important it is. It is a shame in our society, one of the richest nations in the world, that we have the number of dialysis clinics that we do. And there's a way that we can go about, mitigating this by making sure that people get into care on the front end, or they learn everything that they need to know. These individuals that you mentioned, Sean, that are in like stage 1 renal care, we need to be identifying them to be advocates in the community. Reason why is they are confronted with the disease already. They can go talk to someone and let that person know if they're at risk, hey, this is what I'm going through. It's all about relationships in the community. It's all about identifying individuals that, I'll go back to it again. 1, you have passion. 2, the willingness is there to get out and teach people about what's going on. And if you are confronted with the disease, and you know that there's someone in your family that's confronted with the disease, then get the word out, talk to people. Another thing that I think we need to do respectfully is put pressure on the dialysis clinics. I think DaVita and Fresenius can do much more than they're doing other than just waiting for patients to come in. They need to be taking a proactive approach to make sure that people are not falling into this category as well. So, and getting back to AMKD, I want to guarantee you all that 50% of the people that are sitting in these dialysis clinics right now, they have AMKD. They have it. So what do? Once we know that they have it? They need to be telling their family members, you may have AMKD, so you need to be screened. That is a way that I feel that we can move the needle or change the paradigm on what's going on as far as making sure that we're not allowing people to fall through the cracks. Awareness, education, and screenings are so important, people. So important. And we have to find a way to do it. We have to find a way to do it more. Right now, GlomCon, tonight, we have a webinar taking place where we have medical students all across the country that's going to be on a webinar to help them learn how to go out into the community and screen people for this disease. Because if we don't screen them, we're never going to be able to find them. And you know what? If we don't find them, they're going to be in a situation where they're in stage 4 renal failure, stage 5, and they're doomed at that time. Sorry to say it, but that's just real talk. So there's a lot of work to be done, but we've got to find those individuals that can be very energetic and very active in wanting to get out into the community to do this kind of work. You know, I know I do it. I enjoy doing it because at the end of the day, I really want to see people saved. That's what this is all about. It's about people being saved, and we got to take this beyond. You know, don't get me wrong. I mean, I know that we have individuals on different levels doing different things and talking the clinical talk. You know, talking the high level talk. But we've got to get down in the trenches, people. That's where it's at. We got to be able to make a sacrifice to go talk to people, go talk to faith leaders, go talk to anybody that's making a difference in your community. I started out in politics, but you know what? Now I've used that skill set to go out into the community and know how to go knock on doors and talk to people. I'm not talking about social media. I'm talking about getting in somebody's face and saying to them, look, this is the deal. This is what we got to do about this. And I feel like when we do that, we're going to make a difference and we're going to change this whole paradigm as it relates to kidney disease and AMKD in these United States of America.
Amen, Maurice. We're getting to the end of our discussion, but I do want to provide an opportunity for you all to get involved and see if you have any questions. There's 2 microphones near the center up front.
Good afternoon.
Good afternoon.
I love this panel. Anyway, I'm a newbie to the Board of Trustees for the American Kidney Fund. And I want to thank Ms. Burton for being a mentor and a guide to me as I attempt to engage our community at another level. 3 things came to mind. One of the services through AKF is kidney coaches. And I have to complete the course myself. But to your point, we have to train community folks with all the churches that are out here who have health ministries. This is clearly a great opportunity to train healthcare teams within the faith community to replicate the work, get to complete their certification. It doesn't cost them anything. Just do the work. And then they can decide as a group, how can we then move this out in community? Not just in churches, but in public housing communities and other places where people live that need the information. Second thing that came to mind had to do with integration. I stay on the back of my city councilman who was an amputee due to diabetes. And so I brought kidney to the fore. So as of 2 weeks from now, as soon as I get my merch, we're partnering with Black Expo, which is driven by a Black CEO who's in marketing. So we have a nephrologist and we have caregivers, people that also lose jobs because they're loving and caring for people who have kidney disease. And they're putting us on a stage where we can have a direct conversation with the folks to come into that. And they have thousands of people that come in there on that Saturday. So integrating and finding out where spaces are and pushing our way in to get on their agenda is also something that we might want to look at. We learned this in HIV
Absolutely. Yeah.
when people didn't want us at the table. And lastly, to the billions of dollars that they're making off of dialysis in our community, there's one on every corner like a KFC.
And the liquor stores.
I think that this whole process of educating community and making them better consumers. I ended up in front of a nephrologist because I am a recovering hypochondriac who looked at this black box and said, "What is this?" And just being adamant about them explaining on this lab form, "What is this?" only to be told it has something to do with kidney. So training our populations to know what certain indicators mean, to ask their physicians, "I want to see my lab results. And I need you to explain to me what that black box means, because nothing else has a circle around it but that. And what does that mean for me now? And what are you going to help me do about it?"
Thank you so much.
May I respond briefly?
Yes, please.
Yes. First of all, I want to, that's one of our great new board members and ambassadors, and thank you for all the work that you've been doing, especially in South Carolina. You brought up a subject that I actually wanted to mention, and that is the kidney coach. There are different organizations and different approaches to dealing with this issue, and working together, we can make a lot of progress here. One of the things that we realized during COVID is that we could get to a lot more people actually by using other people, by leveraging other organizations. And so we developed what we call Kidney Coach. We will certify anyone who's interested in talking with their constituents, whether it's a social group, religious group, whatever. You want to go out and talk to people about kidney disease, come online, sign up for our Kidney Coach. We will have a session with you. We will certify you. We will provide you with the information, with the tools that you can go out and talk with people. And we can get to so many people by doing this. We're also out in the community ourselves, and we look forward to continuing to have new partners to do that. But we've got to leverage every resource that we have, because one statistic that we have not mentioned today is that kidney disease is actually the fastest growing non-communicable disease in this country. And that's frightening given where we are now and where we might be going if we don't turn it around.
Thank you so much, LaVarn, and thank you for what you do.
My name is Bruce Taylor. I'm a patient advocate. I've been in healthcare for a little over 4 decades and worked with chronic illnesses. I appreciate Mr. Morning's courage to stand up and basically talk about his story, which I think is part of the education. If it could happen to him, it could happen to anybody. But I think one of the biggest challenges in the delivery of healthcare today is time. Physicians do not treat kidney disease. They treat patients who happen to have kidney disease. And the vast majority of those patients, that's not the only ICD-9 that's on the problem list. So by the time you see them in your dialysis centers, they've got uncontrolled diabetes, uncontrolled hypertension, neuropathy, they're losing their sight, their kidney is tanking, they're getting forgetfulness because as they're getting older, we know spiked glucose brings upon dementia earlier. So within the whole cardiometabolic syndrome, it's not about just one organ. It's about, is it the chicken or the egg? Did it start with insulin resistance? I don't know, but you know that everything is indelibly tied with all those organs within the system. And for consideration, you've got a lot of partners out there. American Diabetes Association, the diabetes educators, PAs, MPs, because they're confronted face-to-face, hands-on with the patient, that they have to think through all the other morbidities that that patient has. I was formerly trained as a cardiac physiologist. And I hated those patients that were in fluid congestive failure with tanking kidneys. Because when I practiced in the late 70s, I had nitroglycerin ointment, I had Lasix and nitroprusside. And I prayed a lot. And it's that balance with all those different organs. So I think that's going to be part of the challenge. It's not just the kidney failure progressing. It's a bunch of other things that are progressing hand in hand with it. That I think to the employers, it's expensive to treat the kidney. What are they going to do about that early heart attack? That gets really expensive too. So I think partnering broader with a focus on cardiometabolic syndrome may be something to consider.
Thank you so much, Bruce. There's a lot of discussions and publications and even studies focused on the overlap between cardio, kidney, metabolic syndrome. We know you can look at each one of these conditions. The statistics is going to be very similar as we're discussing here for kidney disease. But I want to wrap this up by saying I thank you all for being here. I think each of us can be not only kidney coaches, but we can be health advocates. I myself, this is personal for me because I have an uncle who was on dialysis and suffered from chronic kidney disease. And so I talk about salt intake and good nutrition amongst my family. I think each of us, armed with information, can make a difference. So thank you for my panelists, and I thank you all. And I don't want to stand between you all and the reception this evening, but this will conclude our panel. Thank you.
Thank you. All right, this is going to be, I think, well, I'll do it tonight a couple of times too.
Good job,
One of
Sean.
my last
Thank you,
times
sir. I appreciate
jumping on
it.
stage and giving announcements. So we will let these guys take their picture. You know,
We took one before.
Okay. But we'll meet tonight for the gala dinner. Remember that we have a cocktail reception starting at 6 p.m. before it, and then this room will be transformed for the gala.
So much.
If you wrote your spoke to the front desk and added your name to the gala list, congratulations, we were able to seat everyone, and so we look forward to seeing everybody.
Thank you, Maurice.
Thank you.
Thanks so much.
Appreciate it.
Yes, of course.
It's great panel. Thank you. Thanks for bringing some
Thank
humor
you.
into it.
Yeah, absolutely. Particularly in the afternoon.
Great.
Thanks.